হ্যালো, 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 হ্যালো। আপনার মাঠ রাখো স্যার।
হ্যালো, হ্যালো।
Hello, am I audible?
Yeah, hi, you're audible.
Hello.
Hi, you're audible. Yeah, Kiran.
Hello. Hello, am I audible?
Yes, you are. Thank you. Good
Yeah.
morning.
Yeah, good morning. Yeah. Hi, good morning, all. We'll start our conference, okay? My colleague Samuke will start with the introduction.
Hi, good morning, good afternoon, and good evening to all participants joining us from different parts of the world. It's my great honor and privilege to warmly welcome you all to the second International Conference on Dentistry and Oral Healthcare. I'm Samukya, and it's my pleasure to be a moderator for this conference today. On behalf of the organizing committee, I sincerely thank all our distinguished speakers, researchers, dental professionals, academicians, students, and participants for joining us today. This conference provides an excellent platform to share knowledge, exchange experiences, discuss recent advances, and explore innovative developments in dentistry and oral healthcare. We are delighted to bring experts from different fields to discuss emerging trends in clinical dentistry, dental research, preventive care, digital dentistry, implantology, prosthodontics, orthodontics, oral surgery, and advanced technologies. I would also like to extend our sincere appreciation to our chair, Professor Dana Yok, as well as to every participant whose presence makes this event meaningful and successful. We highly appreciate the valuable contributions of our speakers and the active participation of every attendee. I hope this conference inspires meaningful discussions, new collaborations, and professional growth. Once again, welcome to the second International Conference on Dentistry and Oral Healthcare. I wish you all a successful, informative, and memorable conference. Thank you.
Hi, yeah, I am Dr. Priyanka Tiwari.
Hi, Dr. Priyanka. Just a minute, please. Our first speaker is Dr. Priyanka Tiwari. Dr. Priyanka is a distinguished prosthodontist, researcher, reviewer, editorial board member, international speaker, and author with over 15 years of professional experience in prosthodontics and general dentistry. She has worked in reputed hospitals, dental clinical chains, universities, and dental clinics, serving as a clinician, educator, and consultant. She is a recipient of the Young Scientist Award and has received the Research Award and Nobel Research Award from reputed research organizations. She has also completed a certification in medical affairs and previously served as head of the department and lecturer at Masai International University. Dr. Tiwari is the holder of a patent for a dental instrument and a copyrighted article. She has authored books and book chapter and has contributed to numerous research publications. Her diverse clinical, academic research and professional achievements reflect her strong commitment to advancing dentistry and prosthodontic care. Please join me in welcoming our speaker, Dr. Priyanka Tiwari.
Yeah, Kiran, thank you so much for the kind words. I will share my presentation and then I will begin.
Yeah, yes, you can.
Okay, I think this is okay. Sorry, just give me a minute. Okay. Okay, can you see my screen and am I audible to everyone? Sorry, just give me a minute.
As we can see your screen.
Okay, all right. So hi everyone, I'm Dr. Priyanka Tiwari. I have been practicing prosthodontics for the past 15 years. Also, practicing general dentistry. Yeah, so you have heard all that already. I worked with a lot of different treatment plans and cases. So today I would just like to throw light on the implant supported crown and bridge, and this is just an overview from the experiences I gained and just an introduction to the topic. All right, so coming to the rationale and updated terminologies of implant dentistry, firstly. So I would like to start with, the rationale, which is the goal of modern dentistry is to restore the patient to normal contour, function, comfort, aesthetic, and speech. So basically in dentistry, you take any of the fields as following. We have around 8 to 9 branches, and upcoming so many more additions to dentistry. We are trying to restore a patient's contour, function, comfort, aesthetic, and speech. So this is basically restoring the function of our orofacial region. All forms of dentistry aim the same. Aesthetic is the concern basically of the patient, and it's of course it's our concern as well when especially we are doing smile designing or implants. There are many reasons why patients are opting for certain treatment modalities. It can be for the function, for the speech, for their comfort. So basically, this is the goal of the whole dentistry. What makes an implant dentistry unique is the ability to achieve the goals. Yeah, achieve the goals regardless of the atrophy, disease, or injury to the stegnomatic system. So we do see some special cases. We do see mastectomies. We see hemifacial defects. We see a lot of things. We see clefts, and we are still treating a lot of the disabilities, which is a part of dental restoration. So we are coming up with new treatment plans or treatment modalities or treatment materials where we can serve the patient. So basically, at the end of the day, we are here to serve the patient so that they can perform their full function, comfort, and for aesthetics. The number of dental implants placed over has increased, from now till 2026. And, of course, nowadays it has been doubled. So you can see, for example, this is just a small data, sorry. I didn't put a lot more of the data of other countries, but these are the main countries I've seen. So what the research says is 230 implants have been placed in the country of Israel. So this is implant placed per 10,000 population. So this is a calculation which has been done. 180 is in South Korea. Sorry. 180 is in South Korea. Italy, 140 roughly is in the Spain and the Switzerland region, 100 around in Germany. So basically, these are just data which you all can read. Yeah, I'm just gonna skip that, sorry. Okay. So when I took the graph, you can see that it says the same depiction of the values in a graph form. So Israel has placed the most implants, then Italy, South Korea, Germany, United States, and the United Kingdom, right? So again, this is just showing, why am I showing this is because the world has progressed a lot, and everyone is running for implants, and they have finally understood what implants are doing, and people are not scared anymore of um, taking treatment which has a little bit of surgical treatment modality. Before, in the times, we used to see that many patients, especially we as prosthodontists, are trying to replace the missing teeth. So many patients are refusing surgery. They just want to go for an easy crown and bridge option, or even easier is a removable prosthesis, which nowadays is kind of becoming obsolete, and it's very good because we are putting unnecessary material and extra prosthesis in the patient mouth, which requires a lot more adaptation than natural prosthesis, which is more like an implant. Yeah. So there are many studies which are being done which compare a natural teeth and an implant. I'm sure many of you all must have gone through that. So I'm not going to throw light on that, but yes, so there are many comparisons which are done. So implant mimics closely as our natural teeth. Sorry. In countries such as South Korea, Israel, Italy, 30 to 40% of the teeth replace corporate and implant, right? Incorporate. So basically everyone is increasing in number. In the US, only 1 out of every 10 teeth have been replaced or incorporated as implant. Again, you can see the graph, the bar chart on the right. Okay. Increasing demand of dental implants. So there are many demands, and why it is important is patients living longer age. So uh, age expectancy has increased. Of course, I agree that it would vary from different countries. Um, Related tooth loss patients have also tooth loss patients have also increased. This was always there, but people are more aware. Sorry, just excuse me. Yeah. Related tooth loss patients have increased. So I wouldn't say it has increased now, but they are getting more and more day by day. However, on the other perspective, I can say that patients are more aware about the benefits of replacing a missing teeth, because as a prosthodontist, every time a patient comes to an OPD, we are trying to explain them of the benefits of the replacement of the missing teeth, right? And to properly complete the orofacial musculature. So the third point is there are more social, active, and aesthetic needs. So now people are more conscious about the way they look and their social involvement, and they don't want a missing teeth. Conventional prosthesis complications. So yes, like I just told you, the best treatment for missing teeth would definitely always be an implant, because it mimics properly, and there is a part of osseointegration which takes place. It mimics the natural teeth, close to 80%. Conventional prostheses do give complications such as removable partial dentures have their age. It is not there forever. So it has to be replaced time to time. It can break, there can be fractures. Yes, there are so many advancement is in the polyacrylate materials nowadays. However, an implant serves a better function than a conventional prosthesis. So the fifth one is inherent advantages of implant-supported restorations. There are numerous. Yes, we will be covering that in our next slides. Right, and then this is for your reference, the picture on the right. All right, so first we come to edentulosum. So basically, as a prosthodontist, our job is to remove edentulism. Yes, we cannot really remove it from the world, but to restore it and to minimize the numbers. So basically, why do we want to do that? It's because there is anatomic consequences of edentulism. So these are as follows: continued bone loss of the maxilla and mandible, negative soft tissue changes in the face and jaw, negative facial aesthetic changes, decreased masticatory function, increased health issues, negative dietary effects, psychological issues, and less socially active patients. So basically, again, coming down to the same points I was emphasizing on in the earlier slides, which are aesthetics and the functions. And if you are having bone loss, other structures of the face are also getting affected. There will be a hollowness, which will also restrict our maxillary sinuses. And so everything here has a consequence. So basically taking care of the aesthetic and the masticatory functions. Coming to the hard tissue loss, Bone requires stimulation to maintain its form and density. So when you do place implants, there is osseointegration, which is a scientific process of formation of the osteoclast and osteoblast, which is forming the bone and attaching the implant towards the bone, increasing the density. So it will basically stimulate in the bone formation. Roberts and colleagues reported that 4% of the strain of skeletal systems maintain bone and helps balance the resorption and formation phenomena. So what I just told you is the resorption and the formation. Osteoclasts and osteoblasts are involved in the whole picture. Okay, coming to the topic. So endosseous implants is designed for placement into the alveolar or basal bone of the mandible and maxilla while maintaining the body of the implant within the bone, right? So these are the implants which are being used. There are two basic types of endosseous implants, which is the blade and the root form, right? Blade and the root form implants can be seen as follows in the picture on the right, right? And you see the mandibular canal. This is just the photo of the mandible, right? And you can see cylindrical implants, screw-based, blade-based implants, which are placed, right? Blade form implants or are also embedded in the jaw like a blade. Yes, there is some failure and success rate through the research. So, however, this is not the most commonly used implants. But anyways, blade form implants are popularized by Linko. The original blade was constructed by the nickel chromium alloy. The 5-year success rate was 55%. So you can see there is a 49% in a 5-year survival in the clinical study of a 77 blade vent implants. Okay, coming to the screw shaped implants. Yeah. Coming to the screw shaped implants, they have become the most commonly used implant designs. You can see now these are very well substituted from the outer. They're very well coated, so it can be textured. There can be different coatings to promote the bone growth. So the original brand mark implant was a parallel walled design, featuring an implant body that maintained the same diameter through its length. Yeah, so there were first Brandmark came with the implant designs and then it went as so forth, right? So you can appreciate the different types of design and the coatings. So of course, nowadays there are more additions to implants and their coats, right? So this is giving an overview of the whole implant as such. So we do have an implant on the lower half, which is self-tape. It has self-tapering grooves. It is for better adaptation in the bone, sorry, and it would give you better osseointegration results. It has buttress threads. These are microblades, which are I'm pointing it with my pointer. You have a collar on top. Yeah, and then the abutment is screwed from up, and over the abutment you put the crown, and then it can be screw retained, cement retained. I will come to that in the later slides. So these are basically abutment screws. Okay, coming to the bone level implants, which is the BLI. Most implants, yeah. Okay, most root form implants can be most root form implants can be described as BLI because they are designed to be placed with the collar at near the bone crest. So as you can see in the photo here, yeah. This design provides flexibility for creation of the soft tissue emergence profile of the implant restoration. So when you have a good emergence profile or a satisfactory emergence profile, the crown structure on top of the implant would look better restored, or it will have a better occlusion. Sorry, occlusion is the word. Occlusion with the adjacent tooth structures. Yeah, so it would be just as height as the adjacent natural teeth, and it can be better restored. Yeah. Okay. Coming to the tissue level implants, which is the TLI. Okay, this is at the level of the tissue, so we're developed to increase the distance of the implant abutment interface, which you can see in the photo, from the bone crest to provide a required biological width. So basically, this is increasing the biological width and taking more advantage. Oh, not increasing. It's incorporating the biological width. So later, these were developed with conical connections and a platform switching, which serves the similar goals. Right, so now we come to the prosthetic restorative options. These options depend on the amount of hard and soft tissue structures being replaced, right? So a very well-known classifications, these are the types and the definitions. So of course we'll go one by one, but I will just emphasize on this first. This is the FP1, which is fixed prosthesis, replaces only the clinical crown, looks like a natural teeth. A fixed prosthesis replaces crown and a portion of the root. Fixed prosthesis FP3 is fixed prosthesis replacing missing crown and a gingival color and a portion of an edentulous site. RP4 is removable prosthesis like an overdenture, which is completely implant supported with no tissue support. Again, there can be a lot of, okay, I will probably tell you in the next few slides about the overdenture. RP5 is a removable prosthesis, again, overdenture supported by soft tissues and implants. So basically, this is incorporating two parts. So the primary stress-bearing areas are maintained in the prosthesis, which is the residual ridge and horizontal palate, part of the palate. In the mandible, is also there. Again, I will, okay. So you can see FP1 occlusion in the photo which I'm pointing, FP2 occlusion and FP3 occlusion. You can see the additions. Here there's more gingival collar which is incorporated, and here there is even more, right? Yes, and this is just the example of FP3 on the right. Yeah. Yeah, this is the same, right? So this is basically with the abutment and screw and the crown, right? So we do have a hole where we can put the screw and we can seal it off. Yeah, yeah, it doesn't really create any other tension or problem. All right, coming to the FP3 prosthesis. So basically this has the crown, the root, and a little bit of the soft tissue incorporation. So yeah, there are basically three approaches: a hybrid restoration of denture teeth, acrylic, and the metal, right? So basically the metal, the teeth, and the acrylic component. Porcelain fused to metal restoration work very well here, PFMs. A monolithic zirconia also works well. This is the all ceramic type of restoration, works extremely well as well. All right, so you can see, yeah, okay. You can see there is a hybrid prosthesis, there is a monolith. So basically the teeth has a little bit of difference. The height also varies. The screw and the implants are almost the same, right? This is the PFM. This is a more natural, more economic option, I would like to say. Monolith is a more expensive option. Of course, it has greater strength. If the jaw and the bone from the dentist scan can support this processes, this is the best one to go for. And there's a hybrid prosthesis, right? Coming to the RP4 prosthesis, here you can see that this is an overdenture. So this is basically a bar type of overdenture, which is on the ridge surface. You have bars and you have screws, you have ball attachments at the back. These are the O-rings which are attached. So basically the patient can actually put it and can take it out. The implants will not move, but the prosthesis can definitely come out and move. It's a very comfortable treatment option, and it works extremely well. Okay, so this is basically a full type of overdenture, which is again an implant supported. Again, this is removable option. But I would like to say that overdenture is a very, very successful treatment modality if it is an implant supported system. There is also overdenture which can be used in a natural teeth situation, or an attachment retained, or an implant retained. So there are so many types of overdenture. The best the research says the best results are given by implant supported overdenture. It gives the best masticatory load forces and an even stress distribution over the arch. So if patient cannot go with a fully fixed option like the FP123, they can definitely go with the RP4 or RP5. Again, there has to be an checkup, an initial diagnosis which has to be done. All the pre-prosthetic work has to be completed, and then the patient can definitely go with this. Yes, this is the mandible. In the middle is the palate with a full coverage palate. Yeah, and these are the implants which are placed basically on the maxillary molar regions. Yes. So yes, in overdentures, there can be a lot of design variations. There can be two implants, there can be all on 4, on 6. So there are many variations as well, right? So one of those processes can be used. Now the debate is always on screw retained or cement retained restorations, which should be used. So some people do agree that screw retained should be used. The other agree that just a cement retained is used. And cements are of so high quality and they're giving so good results. So basically, if these are used, they both work the same way. However, from my experience, I have seen that screw retained are much better. They're just screwed, and there is minimal maintenance which is required for a screw retained. Cement retained has plaque formation, and there is a lot of follow-ups. Of course, overall an implant processes needs a lot of follow-up and recall, which for the maintenance purpose for the patients. All right, so screw retained or cement retained restorations each have their advantages and disadvantages. Your choice of which restoration will best suit the patient depends on several factors. The factors that are affected by different methods of retention of the processes of the implants are uh, ease of fabrication and cost. So there is an ease and fabrication of cost. There is also yes, so there is cost and fabrication difference. Aesthetics is the way they look. Of course, this more depends on the actual teeth material which has been used. So the teeth material which has been used, it can be varied according to the material and the functional needs and the economy of the patient, because like I told you, all ceramic monolith monolith zirconia is a prosthesis which can be of course used, and it will work the most, in certain type of cases. Of course, now I'm not going into indications for PFM and all ceramic restorations. But aesthetics are more, can be used. Again, the axis again is it the front teeth or the back teeth, which axis it is which can be used, also depends on the missing teeth link. Again, occlusion can be restored with first you have to diagnose the patient properly with the occlusal placements. Yeah, sorry, just give me a second. So retention also can be incorporated. Again, I would not say with the cement or the crown retained prosthesis, but it depends on what material prosthesis are we talking about, which type of metallic component, which type of abutment is being used, right? Again, depends also on the incidence of loss of retention There are certain facial forms and ridge shapes and types which do allow a proper retention of certain process and not the others, right? Okay, coming to the passivity of the fit, effect of peri-implant tissues. Okay, this is all in the initial pre-phase, which has to be diagnosed properly. Provisionalization is very important as we see people after placing, after taking the measurements and taking the impressions, we do take some time for the lab to send back the prosthesis. So we do a provisionalization, which is making a temporary crown. Depends on the materials, the cements, and the function of the patient, how well the patient is able to adapt. So if you don't have a lot of high points and if the patient is not doing too much mastication from that area, it works well for a week or so. After that, it gets a problem. It can be easily replaced if there is a problem, but it should not be left alone because we are trying to protect the surrounding tooth structure. Then comes the immediate loading or the delayed loading protocols. Again, I'm not going in details for that. Impression procedures vary. Porcelain fractures are there. Clinical performance of certain type of materials are there, right? Okay. So retrievability is the main advantage of screw retain restoration, which is predictable and it can be achieved without damaging the restoration or the fixture. Therefore, the prosthodontic components can be adjusted. Yes, screws can be refastened, and that's why it's extremely valuable, and it gives you the less. It gives you hardly any failure rate. So fractured components can be replaced within the time, and there it is low cost, and then the cement retain restorations, right? So sometimes you have screw loosening, which can be also fixed. Yeah, so you can see that. Okay, 1/4 has been restored in the photo, right? You can see there is a slight gap. Again, it can be taken out. If there's a problem in the crown, easily taken out, replaced, cleaned, put back, right? Works very well. You can see the masticatory load and the aesthetics in the above photo. Yeah. Screw fractures, yes, there are sometimes screw fractures which are there. Again, depends on so many variables, but which screws you're using, sorry, which implants are we using, and which screws, and there are a lot of placement of the implant matters here, right? So you can see, again, it can be replaced, yeah. Effects on health of peri-implant tissues. So some authors reported that gingival inflammation when using cement retained prosthesis because of difficulty in removal of excess cement, right? And then especially when the restoration margin is greater than 3 mm subgingivally, there is the problem which starts. So peri-implantitis is a very common consequence of placing implants, which is a lot more seen in an cement, used abutments rather than a screw retained. This is particularly common in anterior region when it is recommended to place the implant 3 to 4 mm apical to the CEJ of adjacent teeth to develop proper emergence profile. Okay, so this is exactly how, right? You can see the cement overflowing and it will definitely go down the CJ and it will irritate the surrounding tissues. Yeah, it can cause inflammation. Sometimes we are not clinically able to see. A patient can definitely not clean the area by itself. So that's why there are issues. This is 3 to 4 mm from the CEJ. Yep. You can see the clinical photos here. Yeah. This is 2:1 we are talking about. Yep. Okay, the gingival response is found to be better when using a screw-retained crown since no cement is used. However, if prosthetic retaining screws and abutment screws become loose, granulation tissue accumulate between the prosthesis and the abutment, leading to fistula formation, plaque deposition, and screw fractures, which leads to peri-implantitis. Therefore, it is recommended to retighten the screw in a full arch fixed prosthesis every 5 years. So, okay, tightening is fine. but a regular follow-up is extremely important for such cases. Coming to the immediate loading, screw retain restoration is considered the restoration of choice for immediate loading. This is because using this restoration eliminates the need of cement and associated difficulty of removal of the excess cement from the peri-implant area, right? It gives you more healing and a proper integration of the implants. In addition, screw retain provides the most definitive and rigid splinting when multiple implants are used and therefore enhances the implant stability. A porcelain fracture is common complication observed in implant supported restorations. Again, I would like to argue it doesn't happen so commonly, but yes, when the process goes on for a long time, it can be seen. This is most common seen in screw retain restoration because the screw access hole disrupts the structure. So basically one part of the crown is a little weak on the area. So probably this is the maybe the only disadvantage. However, I've not experienced it a lot in my cases. Yeah, so you can see that is the unsupported veneered porcelain, right? And then we can cover it up with the cement after placing the hole. After placing the screw. So yes, it does happen, but not so commonly. Solution is if you do use monolith zirconia restorations, which is the full ceramic restoration, advanced restorations, it gives you definitely better results. Yeah. So this we are talking about 1-1-2-1. Yeah. Okay, so why no cement space? So will require to no micro gaps, no cement space, no problem with the access cement, one solid piece, less susceptible to fracture. One component is easy handling, right? So you don't have to take care of so many components. Yeah. Vertical restoration space. So basically a 5 mm and 7.5 mm cement retained and, so it basically minimizes a little bit of gap because the cement also takes up some, up to 1 mm of space. Yeah. So these are some guidelines of minimum restoration, right? So it is bone to the opposing contact. So you can see it is advantageous in the screw retained restorations. Yeah, here. Okay, so sorry, restorative material thickness is 1.5 mm. Yeah. And then here is the abutment element, including the collar, is almost like 3.3 mm. And here it is like 4 mm, right? And if you include the collar, it's 6 mm, right? From the implant platform, you can see it for yourself. Yeah. Okay. Finally, okay, coming to my conclusion. In conclusion, implant-supported crowns and bridges offer several benefits over traditional options for missing teeth. They provide improved aesthetics, functionality, longevity, oral health, and confidence for patients. While the process of getting these may take several months, and end result is durable, long-lasting solution for missing teeth, proper care is essential for an implant-supported crown and bridge, and patients should follow good oral hygiene practices and visit the dentist regularly. Okay, so only restrictions here are probably the cost, the time, the patience of the patient, and basically the follow-up, checkups. Other than that, and yeah, that it is a small surgical procedure. That's the drawbacks I see, and it's not really a drawback. I'm just talking from a patient's point of view. These are a few things which a patient has the concern on, which can be taken care from placing a good implant restoration. Okay, thank you so much for patient listening. If there are any questions, please feel free to ask or drop them in my email. I'll be very happy to answer. Thank you so much.
Thanks for your great presentation, Dr. Priyanka.
Thank you. Yeah, sorry. I stopped sharing. Yeah.
Our next speaker is Dr. Aya Dahri. Dr. Aya Dahri is an assistant professor at the Faculty of Dental Medicine, University of Monastir, Tunisia. She is specializing and teaching in general anatomy and implantology and actively involved in research and professional development. She is a member of International Association for Dental, Oral and Craniofacial Research and the Laboratory of Oral Health and Craniofacial Research. She also serves as a reviewer for the Tunisian Dental Journal and is a member of faculty's digitalization committee, contributing to the integration of innovative digital technologies into dental education and clinical practice. As part of the 10th International ATO RECD Congress, Dr. Aya serves as a president of Scientific Committee of FLOW, that is, Future Leaders in Odontology Worldwide, a platform promoting leadership and collaboration among young dental professionals worldwide. She has also received several international research awards at scientific conferences, recognizing her contributions to dental research. Her academic training includes a university diploma in advanced implantology. She is joined awarded by the Faculty of Dental Medicines of Monastir and University of Naples Federico II. She has certificates of advanced studies in periodontology, peri-implant surgery, oral surgery, innovative techniques, health pedagogy, and innovative dental medical English. Her professional interests includes implantology, oral surgery, digital dentistry, anatomy, and innovative approaches to dental practice. Please join me in welcoming our speaker, Dr. Aya Dahri.
Thank you. Thank you very much. Okay, I will share. Okay. Okay. Is my presentation available? Can you see my presentation?
Yes, we can see your presentation.
Okay, very good. So I'll start to say hello. Good morning. It's still morning here in Tunisia. So good morning from Monastir, Tunisia. Thank you for this amazing presentation. And I'm Dr. Aya Dahri, just as I said. I'm presenting with my dear professor, Professor Fatin Ben Amr. This conference, it's about from digital planning to clinical reality, the evolution of fully guided implant rehabilitation. So before we start, let's say that dentistry has come a long way from just working in the barber shop in the Middle Ages
Hi,
to a
Dr. Aya.
discipline.
Hello.
Yes?
Yeah, could you
Yes,
please
hi.
show the PPT in the presentation mode?
Sorry, I didn't get you.
Could you please show the presentation in the presentation mode? I mean, here you can see.
Okay.
Yeah.
You. Okay. Like this, you can see it?
Yes, now it's perfect. Okay. Thank you.
Okay. You're welcome. So and like this, is it correct?
Yeah, it's correct.
Okay. So as I said, dentistry has come a long way from working in the middle, from just be working with the barber shops in the Middle Ages to a whole discipline that was affected by digitalization, by engineering, by different companies, and all of those companies and engineers made dentistry affected with the digitalization. One of the fields that was deeply affected with the digitalization is implantology. And now we are speaking about guided implant dentistry, not just the freehand implant dentistry.
Sorry, Dr. Aya.
And as
I
you can
can't see your screen,
yeah.
your PPT presentation.
Oh, okay. I'll just leave it like this. Can you see it
No,
like
no,
this?
no. I mean,
Still?
you clicked the PPT. Could you please share it once again?
Okay, I will close it. So.
Yeah, no worries. Take your own time, okay?
Just a second.
Yeah. Now it's showing,
Yeah.
okay?
Thank you.
No, please leave it and go to the PPT now. Oh, sorry. We are not.
Yeah. There.
Could you
Window.
please see the
I will
PPT
share.
again?
Yeah,
Yeah,
PowerPoint.
yeah,
Is it
maximize
visible
it.
now?
Yeah, maximize it. Yes, yes. Ah, it is the presentation mode. Yeah, click on it.
Okay, I proceed.
1 minute. I will check and let you know. Oh, could you please zoom it? It is in 70%, I think. Please do it in 100%.
Okay. Is it
Yeah,
correct now?
it's perfect now.
Okay. So from, as we can see from the Middle Ages, it started from 1972, where we have the three-dimensional digital imaging, to then we have the computer-assisted implant surgery. And from the 2013, we started hearing about implant planning softwares. And since then, a lot of researchers, dentists, and scientists dived into knowing and discovering the reality hidden behind the guided implant surgery. And it was proved both reliable, both for patients and for practitioners. For patients, certainly it is reliable. Why? Because we are now using a technology that the patient understands. It is true that yesterday's patients are not today's patients. Today's patients are patients who know and can understand and are accessible to the information. So if you can show them everything, if you show them the pre-planned implant surgery, if you explain to them just with your laptop how the surgery is going to be undergone, he will be less stressful at all, and he will gain confidence in you. And this is the most the deepest and the most sensitive point that we have with our patients, which is confidence. So due to this new technology, due to this guided surgery, you can show them before doing anything that everything is pre-planned from the beginning and the patient understands you. It is also reliable for the practitioner because it is, even if you are 0 experience with, even with the, we have the right to commit errors. So this is why, and this is why this were even for you, the dentist, when you're working on it. And of course, the precision and the predictability, we could not even discuss about this. So during this small journey that we will shape together, our goals for today is to show you the overview of this workflow, the benefits of the guided implant surgery. And certainly my goal today for you is to inspire you to go guided. So first of all, let's speak about the digital workflow. I try to explain for you the steps that you need to proceed from A to Z, how to do from the first day you meet your patients to the last day to succeed a whole complete, fully digital workflow in implantology. It all starts with small steps, and we have a lot of similarities with the freehand or the conventional
Dr. Aya, hello. You are not audible. Hello. Dr. Aya Dari, hello. You are not audible.
Oh God, where did I stop?
I think you have a network issue.
Did I stop here? Did you stop hear me from here?
Could you please share the screen? I think there is a network issue for you. Could you please share the screen once again?
Okay. Did I stop here?
We are not able to see your screen.
Oh my God. Do you see it now?
No.
Oh my God. What's happening? Okay, I will share.
I think you have a network issue, I think.
Now you see it?
No.
Oh, what's happening?
Could you please check your network? I sent for Dr. Fatin the snapshot.
Okay, now do you see it? Can you see it for now?
No. Still no.
قلت علاش حاب على الكونيكسيون غير اللي عرفتها باش تفددني هنا.
Dr. Aya has started screen sharing. وما تمش نتورك ايشو. حط الايفون بتاعي. عملت انت ايفون
نشوفوا ديجا تو.
but we are not able to see the screen.
Okay, is it visible now?
Yes, it's visible now.
Okay, let's hope it is not.
زيدها بتزيد. يعني سمعك فيه.
Okay, so I think we stopped at the patient assessment. Hope you heard me at the patient assessment, okay? Okay. Now let's move on to the data collection. For the data collection, we need CBCT and optical scan. Okay, so for the CBCT, of course, as you know, there are two types of tissue that it shows. It shows bone and it shows the teeth tissue, the dental tissue. Okay, and for the optical scan, it shows both soft tissue and, of course, dental tissue. Just this one to show you that the next time we will on the matching, I will show you why it is important to show and to have these two types of tissues. In fact, if we have the CBCT and the optical scan, that will enable what do we call the matching. And what is the matching? That means that we match the three types of tissues together. We match the teeth, the soft tissue, and the bone of the patient. And that will make a virtual patient that we can plan our implant placement as easy as it could be on the software. Sorry. Do you hear me?
Yes, we can hear you.
Okay, good. So now let's speak about the constraints that need to be collected from the surface scan. So for the surface scan, of course, it has to be collected otherwise from a physical model. That means you do your physical impression, you send it to the lab, and the lab does the impression. Or to be more precise, you can do it in your own, if you have it, of course, in your own clinic or in your own dental practice. So it could be even from an intraoral scanner. Of course, for a better matching, for a better precision, you can do it with an intraoral scanner. This is the first data that you need to collect. The second data, as I said, they need to collect the CBCT. But of course, the CBCT need to reply to some constraints, like does not have some artifacts, and it has to be done with maxilla and mandible separated. This is very important. Why it should be performed with maxilla and mandible separated? Why we need to ask our patient that when he performs the CBCT, we need to see the occlusal surfaces, because those occlusal surfaces are the key that will make the matching happens, because those are present in the optical scan and in the CBCT. And this is why they are the common point between them, and they could be matched. So if you have it, of course, the CBCT in your private practice, you can do it with a separated maxilla and mandible. If your patient will go to another radiological center, you just sorry, you just ask him to separate his maxilla and mandible, so the CBCT can show the occlusal surfaces. Now, there are always some problems with patients suffering with a CBCT. Some patients usually refuse the CBCT treatment, and they say that there's a problem with the irradiation dose. And this is your job to persuade him that the irradiation of CBCT is very low regarding to the CT scan, the normal CT scan, and it is dosed from 70 to microsievert. Convince your patient that every day we are exposed to an average irradiation of 6.6 microsievert per day, as just the way that we live, the air that we breathe has this irradiation dose. And this dose is the same dose that you can do if you fly from a plane from the two extremes of the United States. So, which is the same dose as you receive a CBCT. So why your patients accept to fly in the plane and does not accept to do a CBCT? This is the same way. So this is why you need to convince him that the CBCT irradiation responds to all of the norms of the radio protection. Now, we have the CBCT, and from the CBCT, we have to extract a file that is called the DICOM file. And from the intraoral scanner, we extract the STL files. And those are the two key files that are needed for our future planning, implant planning software. Of course, some researchers proved that there's a lot of files that could be extracted from the CBCT and from the intraoral scanner, but those two specific types, the CBCT, the DICOM, and the STL, prove that they are the most precise ones that can be performed on your future software. Now, once our data is collected, we need to manipulate the data. So can you hear me, guys? I always have to check to verify that you are listening to me. Do you hear me?
Yes, we can hear you.
Okay, that was close. Okay, now the data manipulation, we have our STL file from the intraoral scanner, we have the DICOM file from the CBCT, and now we have to manipulate the data to plan our implant. So the question is, we are in a world that is full of softwares of planification. And the question is how to choose the correct implant planning software. In fact, the market is very full with those softwares. And the most recent softwares that show flexibility in individual design. And you can choose the one that you are that you want, because most of them are just the same and they have mostly the same precision levels. So do not worry, choose the one that you chose to choose, and there's no difference between them really. So once you have your software, once you have your data, we can now move on to the real planning. So before we start planning, we have to define the area of interest. The DICOM file, as you can see, the file from the CBCT is usually very, very heavy. And of course, if you have this file that is too heavy, you need to reduce it. Just select the zone of interest of you. That means if you have an implant in the maxilla, why would you just leave the whole head of the patient in front of you? Just select this the zone that you are working on. That's it. That's to enlighten your software next wise. And now we will move on to the matching. So as I said, I have my DICOM and I have my STL, okay? And the common thing between them is the teeth. And the superposition of the different elements will make a key phase in our planning of the guide. So, as I said, 3 points define a plane. We have the STL file, we have the DICOM file. We need to choose 3 matching points. That means point A on the STL file, the same point A on the DICOM, B, and point C. And from those 3 points, we can make the matching together. We can make the whole, our virtual patient together. As you can see, we have the tooth, we have the soft tissue, and we have the bone. And from here, we can start the planning. As you can see, from here we have the STL file, and this is the DICOM file. We choose 1 point and we refer to the DICOM file, and from here you have the whole planning together. Okay, now I move on. Once we have the matching, once we granted the matching, we move on to the next step, which is a very crucial and important step, which is the nerve tracing, the anatomical elements. We need to indicate to our software which anatomical element we need to recognize him and to make him know our anatomical. I do not like the word obstacle, but it's the noble anatomical structures. They should recognize them so that the implant does not invade them. The most important element, of course, you all know, is the mandibular canal, but there are too many other anatomical noble structures that we need to respect. So this is why a lot of studies work to show that, to make that the software do an anatomatized segmentation of the mandibular canal. And not only the mandibular canal, but also the maxillary sinus. Some softwares now can recognize easily the maxillary sinus, and the maxillary sinus is also an anatomical element we need to respect. And if you invade it, you need to know how to do it correctly. So also there's the incisive mandibular canal. This is an anatomical element that we need to respect. There's not only in the mandible, the mandibular canal, but there's also the incisive mandibular canal. It's also a noble anatomical element. We need to recognize it. We need to make our software know it so that our implant does not invade it. Now, after the everything is from the ABCs, so I'll go back from here. We did the definition, we did the matching, the nerve tracing. Now we move on to the real game, which is the planning. I think most of you just wait for the planning. So all of what we done is the preparations for the planning. We do not jump, we do not skip any step. We respect all of the different steps to grant a perfect and a correct implant planning. There's a concept that we need to respect. In fact, the implant planning is not just we need to place our implant in the bone and we need to just get away from the anatomical concept. There's a concept that is called the crown down concept. The placement of the implant should be totally dictated by the prosthesis. This is the emergence plane of the implant should be emerged from the center of your future prosthesis. This is what we call the crown down concept. That means if we have a sufficient alveolar bone, before we place the implant, we make our provisional prosthesis. We have the library of the software. It offers all of the different provisional prosthesis. You make your prosthesis, and based on this prosthesis emergence, you create your implant, okay? So then once you created your prosthesis, everything is ready. You have the feasibility to place your implant, as of course respecting all of the different other constraints, respecting the emergence from the prosthesis and everything. Of course, the parallelism between the implants themselves with the other teeth, respect the anatomical constraints, all of those elements, you should bear them in mind to place your implant perfectly. And trust me, once you plan 1 or 2 implant placement, it's going to be a very lovely and amazing game for you to do so. Now, afterwards, the manufacturer of the guide and the prosthesis, you place your sleeve, the sleeve that's where the different elements move on to place your implants, and of course you delimitate it, and of course afterwards you print your guide. Of course, there's a lot of types of guides. If you have 1 or 2 teeth that are absent, or you have a residual tooth, we have the surgical guide with dental support. It's very easy. You just place it, the tooth support the guide, and here you have your sleeve, and you just move on to place your implants. And there's other guides when you do not have tooth at all. You have the mucosal support, when you have a flapless technique, when you do not have to enter within the bone, you just have the mucosal support. Here they are, the pins that you will place within the mucosa. And
Hello. Hello. Dr. Aya, you are not audible.
Good morning.
Dr. Aya, you are not audible.
Can you hear me now?
Hi, Dr. Dana.
Hi.
Yeah,
Hi,
now
doctor.
Dr. Aya is presenting the speech. I think she has a network issue. Dr. Aya, you are not audible. I will call her, Dr. Dana. Just give me a moment.
Yes. In the meantime, I want to say congratulations, Kiran, for organizing again another successful event. Hi, Dr. Esda Hamed Ali. Esra, how are you?
Hi, fine, thank you. Hello, doctor. How are you?
Wonderful. I'm here in New York, in Long Island. And I'm so happy to be part of Kiran's team of doctors in more than 32 countries. And thanks to him, I learned so much of research from so many neck of the woods in the world. And what do you do, Dr. Esra?
Yes, I'm Dr. Isra Hamid. I'm lecturer of pediatric dentistry and dental public health at Faculty of Dentistry, MTI University in Galileo University in Egypt. And I am so happy to join you today in your great scientific event and research. And thank you, Kiran, and thank you, Dr. Amla. And today, please give me the chance to share with you my most recent study under the title. Yes.
We will share, but let's wait for Dr. Aya to come back because in the
Okay.
program for
Of
us.
course. Of course.
Where in Egypt do you live?
In Cairo, in New Cairo.
Oh my God, I wish so much one day to arrive to Egypt.
You will be more than welcome. And now I'm in Sahel. I'm not in Cairo. I'm in Sahel taking my summer vacation.
Summer vacation, right?
Mm.
Oh my God. So I represent European Medical Laser Association, and let me change the name. My name is Professor Dana York. I've been a professor at NYU, New York University Dental
Yes.
School
Yes, of course, I know.
in here in America. Hello, Dr. Aya. You are
Hi.
back.
Yeah, I'm back.
Yes,
I
yes.
had some
5 minutes.
internet
Just 5
internet
minutes.
problems. Yeah. Hi.
I
I will
am
just finish
Professor.
with the case report. Yeah.
I'm Professor Dana York, and I am so happy to listen to your lecture.
Thank you.
Thank you very much. Thank you. Okay, I will just finish with this case report. Okay. Uh, okay, do you see my presentation?
Yes.
Okay, very good. Okay, let's finish with this case report. So, as I said, we equipped our provisional prosthesis with radio pack markers, and of course, we did the radiological examination, as I said, with the dual scan. And from here, we have the bone superposed to the provisional prosthesis, superposed to the soft tissue of the patient. We have our virtual patient, and now we can plan as easy as it goes. And as I said, the importance of the crown down concept. That means the temporary prosthesis, whether wise you fabricate it on the software already exists with the patient as it is for this case, it is totally the one that guides our implant positioning. So this is the virtual implant guide, as I see, the planification of the implant planning. Also, we had the opportunity to concept even the temporary prosthesis so that the patient, the day of the surgery, he will go home with his temporary prosthesis, with his new smile. So this is the surgical guide, and of course the surgical protocol. We check the fitting of the guide, then we do the drilling. Of course, the first drill is the tissue punch. We remove the tissue punch, and then we move on to the other drills. Just we respect the sequence that the software gives to us, and of course according to the implant system that you do. Then, of course, this is the after moving the punch. Then, of course, we fix the pins. And of course, from here, the drilling sequence. It's very easy. As I said, just respect the drilling sequence and it's going to be very flowable. Okay. So once we finished the drilling sequence, we place the implants, the multi-units in place, and then we placed, of course, as I said, we're going to do the provisional prosthesis. So I'm going to place the provisional abutments and my multi-units in place, just as it's seen here. And then I will put on my provisional prosthesis and, of course, fill in the gap with the fluid resign. And from here, our patient will go home with his total finished prosthesis. So we even had the opportunity to scan for the provisional prosthesis, and the patient goes home with his own provisional prosthesis. Now, as you can see, I'll just skip this case report because we have no time for it. And we move on directly to the conclusion. Okay, so as I said, the guided implant surgery offers security, precision, optimization, visual communication with your patient, comfort with your patient, even you can trust what you do. Compared to the freehand technique, errors likely to occur, and there are no possibilities to commit errors, and we have also a lot of precision when you are working with guided surgery. And of course, you can avoid complications. The limits also, there are always limits. The price also is higher. There are some risks of stability of the guides, the irrigation. You have to have a good quality of image if you have. But if should it be today's unique therapeutical choice? No. Also, always we can never deny the influence of certain techniques that have proven their success rates. For instance, this is the FAST guide, the Alain Simon Pierry, God bless his soul. He died 2 years ago, but due to him, we use the incisive canal as a parallelism guide to place the implant. If you see this radiological exam, you can see you always say directly, this is guided. This is not guided. This was placed freehand, but due to the incisive maxillary canal, it was perfectly parallel, even better than a guided. This is why we should never forget about the freehand technique. They complete each other, they help each other, and this is why we need to take advantage of each technique itself. And this is it. Always never forget that we have also the dynamic is now dynamic navigation. You place your image just in the same way, direct. Your drills. Thank you for your attention. Thank you. This is the team that we work together. We are a whole family. I am proud to belong to this clinic. And my dear professor, my mentor, Professor Fatou Ben Amor, she's always guiding me. And thanks to her, we are every day trying to evolve. And thank you for your attention. I hope you like this conference.
حلنا بصوتهم نزلت.
Did you hear me?
Yes, we can hear you.
استنى.
Professor Dana. Professor Dana. Hello.
We finished.
Are there any questions?
شوفوا نختاروا حاجات وكهو.
Thank you very much for your great presentation.
Thank you. Thank you very much. Thank you.
Professor Dana, do you have any questions for Dr. Aya?
Dr. Aya, congratulations for the beautiful presentation. I need to learn from you to do this. I need to learn. I need to come and learn from you because I have not such an advanced version that I'm using in the past. So let's meet very soon. Thank you, Kiran, for inviting me to this wonderful event. And Dr. Aya, do you know in spring we have an event in Dubai? Are you gonna come?
Yeah, I hope so. In spring, right?
Yes.
Okay.
Kiran, when is the event? When is the event, Kiran?
Which event, Dr. Dana?
The one in spring in Dubai. When is
yes.
it? What is the
It's
event?
in March.
The IDEC, right?
The idea.
It's in March 3rd.
Oh, great. Oh, yes.
So then I have the chance to learn from you
I hope
directly.
to see you there. Yeah.
Thank you for the beautiful,
you.
inspiring presentation.
Thank you very much for your beautiful words too. Thank you.
Now Kiran will give the hand to the next speaker. I'm at the age of retiring now, so I started to do much more administration work and research, let's say, and enjoy life. But in a life of dentistry that I had, I can say that the practice of a doctor in dental surgery, it's made by the patients this doctor received, and by the patients this doctor refused. It's the same in any doctor profession or medical healthcare provider. And now we welcome Dr. Asra from Cairo. Please, Dr. Asra, can you present? Or
Yes,
Can
thank you,
present?
Dr.
Our
Dan.
speaker is Dr. Esra Hamid Ali. Dr. Esra Hamid Ali is a lecturer specializing in pediatric dentistry and dental public health, with extensive experiences in academic teaching, course coordination, quality assurance, and clinical dentistry. She currently serves as a lecturer at the Faculty of Oral and Dental Medicine, MTI University, and has also worked as a lecturer at Galala University and Helwan National University, where she served as Dental Public Health Core Director. At MTI University, Dr. Ali has served as a course director for preventive dentistry, community dentistry, dental ethics, and legalities, as well as deputy director of the Quality Assurance Unit and head of its financial resources sector. She is also an editorial board member of EC Pediatric Journal. Dr. Ali earned her PhD in pediatric dentistry and dental public health from Al Azhar University in 2021 and her master's degree in the same field from Ain Shams University in 2016. She also holds a diploma in hospital management. She has clinical experience from Kobri El Koba Armed Force Hospital and Ain Shams University. Dr. Ali is recognized for her strong clinical skills, dedication, creativity, and commitment to academic and professional excellence. Please join me in welcoming our speaker, Dr. Esra Hamid Ali.
Thank you so much. Thank you for this great presentation. Thank you. I'm so happy to be with you today to share with you my most recent research that is now in the final process of application. And please let me share the presentation with you for my research.
Dr. Esra, you're not.
Yes, just I'm sharing the
Okay.
presentation. Please let me know. You can now see the slide? Yes?
yes.
Yes, okay. My research is under the title of Bacterial Contamination of Eco-Friendly Charcoal Infused versus Standard Nylon Toothbrush Bristles. As we all know that toothbrush bristles can become contaminated during the routine home use, and by coincidence, it acts as a microbial reservoir for organisms originating from the oral biofilms in addition to the environmental sources. As we all know that we also store our toothbrushes in bathrooms, and the bathrooms is contaminated with bacteria and other aerosols that will add to the microbial contamination to the toothbrush. And evidence showed that toothbrush comes contaminated either directly from bacteria in the saliva or also from the surrounding environment. And as a result, many researches has been taken place to form decontamination methodologies for the toothbrushes, either chemically or physically. However, all these methods meet some limitations in its implementation regarding inconvenience, time requirements, or any other cost concerns. So nowadays, product-embedded antimicrobial strategies such as toothbrush heads or bristles encompassing antimicrobial materials have attracted increasing interests. And a new era of toothbrushes called charcoal-infused bristles, where the bristles are made from charcoal, marketed now as an eco-friendly alternative to standard nylon bristles, claiming to reduce bacterial contamination and intrinsic antimicrobial effects. On the other hand, we all know nowadays across the world and specific in dental public health, there is an increased concern with green dentistry. And I've presented with you, Dr. Kiran, I think 2 years ago, about another issue talked about also green dentistry. Okay, so because I'm very concerned with this field. Green dentistry, as we know, aim to reduce healthcare associated waste products and encourage environmental friendly consumer choices. As we all know, the conventional toothbrushes contribute to the huge plastic waste streams where millions are discarded daily and annually, and this lead to many threats to the environment. So we in the market now we see eco-friendly toothbrushes combining biodegradable components such as bamboo handles, as with this study, charcoal-infused bristles to decrease the threat to the environment. But we need more research in order to evaluate their infection control relevance in antimicrobial claims. So that's why our study here aim was to compare bacterial contamination of charcoal-infused bristles versus standard nylon toothbrush bristles and evaluate the contamination after 1 day of use, T0, and 1 week of use, T1, to compare outcome in both children and adults. This ex vivo microbiological study was conducted at Faculty of Dentistry at both MTI University and Swiss University, where 48 systemically health participants were included and dividing into 2 groups, 24 children and 24 adults. The age of children was between 8 to 11 years, and for adults was between 18 to 35 years. And participants were allocated to both groups, where each group contains 12 participants, according to the brush type. Eligible participants were all systemically healthy individuals that agreed and offered consent to participate in the study and follow standardized brushing and storage instructions throughout the study. However, other Patients were excluded if it was found during the first diagnosis that they have any presence of open, untreated Kehr's lesions, poor oral hygiene, severe gingival inflammation, throat infection, irregular brushing frequency, unwillingness to use these new brushes, use of mouthwash, or medically compromised condition in order to avoid any bias in the study. Regarding the methods, all participants received standardized brushing and storing instructions according with common oral hygiene instructions by brushing twice a day, one in the morning and one in the evening for 2 minutes, using modified bust technique in toothbrushing, and rinsing of bristles under running water only without any finger cleaning. And they were instructed not to use any mouthwash and not also to cover the toothbrush heads with caps. However, we instructed them to store the toothbrush in open air away from any obvious contamination inside the bathroom environment. And then each participant after the first day received a sterile pouch to return the brush and took another brush to complete brushing with it for the upcoming whole technique. And also after the 1 week, second brush was returned in a sterile pouches. And then after the 1 day and 1 week of use, only 1/3 of the crystal stuff was aseptically cut and processed, and samples suspended and plated on blood agar jars, and cultures were incubated anaerobically using the gas bag system at 37 degrees for 48 hours, and bacterial contamination was quantified by the colony forming units. Results concerning the overall population at T0, which is after 1 day, there was no statistically significant difference between eco-friendly or charcoal and nylon toothbrush groups. However, after 1 week at T1, eco-friendly toothbrush group demonstrated significantly lower values than the nylon one. Regarding the children group versus adults, in children, no statistical significant difference between eco-friendly and nylon groups were observed either at T0 or T1. However, in adults, at T0, no statistical significant difference was observed. However, at T1, after 1 week, eco-friendly toothbrush users exhibited significantly lower values than nylon toothbrush users, and overall, a statistical significant reduction from T0 to T1 was observed in both children's and adults groups. So as a conclusion, charcoal-infused toothbrush crystals were associated with lower bacterial contamination than standard nylon crystals after routine home use, and the clearest reduction was observed, of course, after 1 week of use, and especially in adults. I finished this short presentation. Hope that you enjoyed it. Thank you.
Thank you very much for your great presentation, Dr. Esra.
Thank
Dr. Dana.
Thank you. Any questions?
I think there are no questions. Yeah. Dr. Dana.
Okay, thank you. Thank you so much. Thank you, Kira.
Kiran, I
Dr.
have technical problem myself,
Okay.
and I have a delay.
Okay.
I cannot replace the next speaker. I might need to change computer.
Okay, Dr. Dana. Until
But
then, I
in the
will call you.
meantime, as we have
Yeah, you can.
Okay, okay, Dr. Kiran. Yes, Dr. Dana.
hi, my computer have a little trouble as well.
No worries, no worries. It's okay.
And I have to change computer.
You can restart the
Okay.
laptop, Dr. Dana. We will wait for you.
Thank you. Now, Kiran, tell us more about your beautiful project. What conferences is there going to be next? Tell us the program for
Yeah,
2027,
for
for end of
7.
2026.
There is an artificial intelligence, data science, and machine learning conference in March 5 and 6. And after that, we have one more conference, public health and global wellness, and precision oncology and cancer research on March 3rd and 4th. And moreover, we have one more conference on November, EMLA,
Yes, we do.
Bangkok.
Yes. Or on Zoom. It's a hybrid conference.
Hybrid conference.
Where it will be?
In Bangkok.
Okay.
Can you come?
I don't think so, unfortunately.
We should make it in Cairo.
Yes, of course. Welcome.
Or in the resorts.
Yes.
I think we can collaborate with universities, Dr. Dana.
In Cairo.
Yeah, I think so.
Oh boy, oh boy, oh boy. I would love that. If we can collaborate, that would be wonderful. We can come and make a artificial intelligence course or lasers in medicine and dentistry course. That would be very nice.
Yes, of course.
So I'm trying now to reach my my other computer. And what can I tell you about? About my experience in dentistry, I want to show you some of the
About
our research.
our past conference, Dr. Dana, which was held in New York.
Yeah, can you share slides from our photos from our past conference? So we show all.
I think the photos are not on this laptop, Dr. Dana. I will check once.
I am on both computers now, setting up. So as I started sort of like permanent vacation, I am very happy to be with you today. Very, very, very happy. And what can I tell you is that the world is changing and we cannot be careful enough, both for our health and for our practice and to protect our licenses as doctors. Dentistry is the second most dangerous profession. Why? Because we sit in patients' mouth, so we can get contamination, we can get as much uh, uh, terrible disease happening. In the time of COVID back in France, our practices they got closed, and we had to be home or in some cases on our boats. That was in France. The rest of the world, I don't know, but we couldn't work. Now we work, and we doing we are doing our best. We are doing good. We are doing very good. Just because of the situation in the world, I think more and more practitioners they get to be trying to escape the profession. Dr. Esra, if you can remove the share of the screen so I can share my screen. I cannot share my screen because the other doctor got the screen.
I said your PPT. I mean, your banner is on the.
Yes, but it says you cannot share the screen because somebody else does.
Yeah, now you can share the screen. Could you please check
Oh,
now?
let me check. No, I still cannot share because other participant is sharing.
Could you please check now?
1 second.
Are you able to share the screen, Dr. Dana? You are on mute. You are on mute, Dr. Dana.
Can you hear me now?
Yes. Share the screen in one laptop, Dr. Dana, so that it will be.
I'm working on it. In the meantime, let me tell you, I'm working on the both computers. Let me tell you the definition of lasers therapy, which is so used in dentistry. Laser therapy is a treatment with light to remove inflammation. The treatment with the light is used for a post-surgery, post-extraction, post-root canal, post-gum preparation for crown, post-implants, in preparation for implants. And what are the application? Anti-inflammatory effect, an immediate effect, and regenerative
Dr. Dana, could you please share your screen?
regenerative effect.
Yes, share the PPT.
Can you hear me now?
Yes, Dr. Dana. Dr. Dana, in one laptop, mute, okay?
I have opened one laptop now.
No. I am saying that mute all the sound in one laptop, okay? You have to mute the laptop sound, okay?
Kiran, I think you should take the next speaker.
Okay, Dr. Dana.
And at the end of the day, if that fails, you have still option of going to the crown. And as you can see in the other side of the picture, you see the patients that attended with the multiple composite restorations, defective, and the restoration which are recommended to put a ceramic veneers instead of composites. I'm not against the composite, but it has its own limitations. Today we're talking about the advantages of the ceramics, apparently. So these are the advantages of ceramics, that you see the anatomy, controlling the anatomy is much better than the composite, and also durability of the ceramics are better. It has its own downsides, but we will discuss all this in the lecture. But it's a great tool in hand. So it's very popular kind of a material that we need to learn about it. There are different ways of classifying and categorizing the ceramics. I try to put all things together to present you as a package, but in a very simple way. As I said, there are different materials around. It's difficult to work it out what is what. But there are basic classifications. Based on the crystal structure of these ceramics, generally ceramics are classified as two types. They are made of crystals and the amorphous matrix, which is glass matrix. And the amorphous glass matrix is a weak structure. All of the ceramics that you see in the market is a combination of these two. You have a bit of matrix, you have a bit of ceramics. The ratios are different. Apparently the composition is different, but in terms of crystal structure, this is the difference between the different type of the ceramics. So the glass matrix is not particularly strong, so it's a weak part of ceramic. But the advantage is that it has high translucency. So the more glassy phase you have in the structure, the more translucent the ceramics is going to be, and the more aesthetically pleasing for the patients. At the same time, it's etchable and bondable to the tooth structure. That gives an advantage. That actually compensates the weakness of this phase, because when it's bonded to the tooth structure, it becomes a part of tooth structure. And with the biomimetic approach that these days we follow, we replace like with like, we replace the enamel with the ceramic, which is very similar to enamel, and we replace the missing part of dentin with the material which is similar to that, for example, composites. So this material, if it's bonded to the tooth structure, becomes ideally part of tooth structure and regains its strength. So that weakness goes away. Plus the fact that it has better translucency. The crystal part on the other side, in the composition is almost the same, but the arrangement of the atoms and molecules are different. And it's very organized, it's not random. It gives a kind of crystalline structure, which is mechanically very strong, but is difficult to etch and bond. So it's itself has a good strength, but it cannot bond to the tooth structure, so it doesn't benefit of bonding to the tooth structure. And this kind of ceramics, which has more of crystalline, they need to be cemented to the tooth structure because you can't etch them and bond them. The ratio of the crystals to the matrix varies between the crystals, different types of the ceramics. And then, for example, Emax or lithium disilicate ceramics have like around 40 to 50% of matrix. Some ceramics has more, some ceramics has less. So based on this classification, we have two groups of the ceramics: glass matrix ceramics, which has a big chunk of amorphous matrix, which is etchable, bondable. In this category, you have feldspathic ceramics. These are the early ceramics developed in dentistry in early 20th century. They failed a lot because there was no bonding to the tooth structure. They were cemented, and that because of that, most of these restorations, especially on the posterior area, failed and fractured, and it was not a favorite restoration. So over time, They strengthened it by adding metals, which we had the PFM porcelain fused to metal ceramics. On the other hand, we have polycrystalline ceramics, which basically they are oxide or metal oxide compositions. They are almost fully crystallized. For that reason, they have a good mechanical strength, but poor bondability. They cannot be etched or bonded to the tooth structure. Plus, because they have crystal structures, they are not aesthetically pleasing. So because they scatter the light and they look opaque. So as you go in from the glass matrix ceramics, which is the feldspathic has the highest one, is the most translucent, and then lucite-based ceramics or lucite reinforced feldspathic ceramics. These are the type of ceramics which are reinforced, and they develop a certain kind of crystals, which are called lucite, are the second. And then lithium disilicate is in the middle in terms of aesthetic and in terms of strength. And then zirconia is the best one. Alumina is out of market because zirconia has all the advantage and there is no point of using alumina. It's been in the market for a short period of time and then disappeared. I want to give a little bit of information in terms of terminology because the terminologies are confusing in the books and in the text, unfortunately. Dental ceramics and dental porcelain. Students keep asking me, what is the difference? Sometimes you refer to some ceramics as a porcelain, sometimes you call it a ceramic. What is the difference? And the same goes to all the textbooks. This is the definition from the glossary of the prosthodontics in the US and also British standards, which follows the same definition. Dental ceramic, by definition, is an inorganic, non-metallic material, which is specifically formulated for use when processed according to the manufacturer's instruction to form the whole or part of the dental restoration or prosthesis. So it's a very general term, whereas dental porcelain is predominantly glassy dental ceramic materials. So the materials be mentioned as a glass-based materials, we can call them porcelain. But the zirconia alumina cannot be called as porcelain. They are under the category of ceramic. Porcelains are also ceramics. So if you call feldspathic porcelain or feldspathic ceramic, both are the same. It doesn't make any difference. The initial ceramics which are developed, as I said, early 20th centuries, they were feldspathic ceramics. There was no bonding ability. They had and still they have inherent flow inside the fitting surface of the crowns or interior surface. And there was no bondability. And because of that, crack would initiate from those defects inside the fitting surface to the surface, and especially on the posterior areas, all these ceramics were failed because they were cemented, they were not bonded. That's why they become redundant for a while. Then towards the end of 20th century, we start developing the proper ceramics, the stronger ceramics. And then we started bonding the ceramics to the tooth structure and we learned more about the tooth structure and the mechanism of bondings and the techniques developed and protocols developed and improved. Now we have the chance of, again, using this type of ceramics, which are aesthetically still the best ceramic in the market. In other category, we have ceramics classified in two groups. Ceramics which are in one part, so the whole ceramic is made of one block material, is called monolithic, or the ceramic which has a strong core, a strong ceramic used as a core, like very similar to porcelain fused to metal. Metal is used to reinforce the ceramic on top of it. And the same way, strong ceramics came to the market and replaced the metal. This is called layered ceramics. So if you look at the image, probably gives you a better idea what's the difference between the layered and the one layer ceramic. So these are the different type of ceramics that can use as a core. For example, lithium disilicate, we said that in terms of strength is the strongest glass-based ceramic. And then glass infiltrated ceramics, InCeram, we're going to discuss that, was another strong ceramic. Alumina, which is not in use anymore, but historically, yes. Zirconia is the most advanced ceramics and a very strong ceramics. They are not bondable, but they are very strong to be used as a core material. And on top, they are layered with the more aesthetically pleasing ceramics. I personally don't recommend this layered ceramics for posterior restorations because of the high failure rate of these layered ceramics, which is weaker, and there is a bit of lack of compatibility, let's say, between the core ceramic and the top ceramic, which is used for the aesthetic reasons, because they are different materials. They're two different elements. But they are a good tool. I mean, these layer ceramics for the anterior teeth when you have an issue with the coloring, covering the discoloration or masking the discoloration, because these core materials are the strong ceramics, particularly zirconia. They are opaque. So one of the indications to mask the highly discolored teeth. And then on top of it, you have translucent ceramic, which gives a better aesthetic. New technologies developed a new type of zirconias that we kind of discuss, which provides both of them. And there are two types of ceramics, they bond together well, so that gives a better option. Monolithic ceramics, as we said, again, a different type of ceramics can be monolithic, almost all of them. In one piece, they are stronger, especially zirconia on the posterior teeth. But on the anterior teeth, because of the poor aesthetic of zirconia, because of the opacity, if they are not covered with the aesthetically pleasing ceramic, they look very opaque. And normally we don't use on the anterior teeth. But the lithium disilicate, for example, glass-based ceramic can be monolithic and even on the anterior teeth because aesthetically they are still good. This is another example on the anterior teeth. You can see, as I mentioned, on the left side, you see a glass-based ceramics made. It's a monolithic ceramic. And compared to that, on the right side, you see the zirconia as a core used and layered with the glass-based ceramic. The glass is very translucent, but the core is opaque. So first of all, you have to cut too much of tooth structure to create a space for both in this type of restorations, like PFM, very similar to that. The only difference is that the metal is replaced by high-strength zirconia. And also, it gives a bit of opaque appearance, so it's not aesthetically as good as like the other glass-based ceramics. But the advantage is that they cover the heavy discoloration. If I want to classify the ceramics based on the sintering, based on the manufacturing, this is a different category. The reason I'm mentioning is that you need to, I mean, an dentist needs to understand the difference between these 2 or 3 types of kind of classification. It's easy and it's common to see that in the authors, they mix up these different techniques and the materials and crystalline structure, and it makes it really difficult to work it out what materials they used. Sometimes they refer to the processing technique, sometimes they refer to the crystalline structure, sometimes they refer to the chemistry structure, and so on. So it's so confusing. But I tried to divide them to different categories to make sense of this. In terms of processing, sintering is the oldest technique in which you have a powder and liquid, you mix them together, reheat them, and the liquid evaporates and the particles dissolve and become soft, let's say, on the periphery, and they join or fuse together. The clear example of this, the oldest ceramic, feldspathic ceramics, alumina reinforced feldspathic ceramics, lucite reinforced feldspathic ceramics. These are the kind of old ceramics. Is still gold standard, despite the being old. The reason is all manually made, and it kind of shows the art and and the capability of the technician, and you can build up all the fine details in the restoration in terms of the stain and different characteristics, surface characteristics, and so on. So still gold standard, but as you can see, it's expensive because of the time that is spent on it. In terms of strength, they are not very strong, 105 to 160. The weakest one is the feldspathic ceramic in this category, and the lucite reinforced is the strongest one. Another technique is heat pressed, in which you have a wax pattern. You make it in the form of crown, full crown, or core, or whatever you want, substructure, and bury inside the investment, and you heat it up and burn out the wax. Then you heat the ingot of ceramics, which are made for this purpose, and then plunge it into the cavities or the voids that is created inside. That's why it is called heat pressed. In this category, examples are the lucite-based ceramics. IPSM press was probably the first one that's developed, commonly available. And then lithium disilicate-based ceramics, which they call, dentists now popularly called it EMAX. Initially, it was Empress 2, that is improved, and then they called it IPS EMAX press. And lithium phosphate is another ceramic in this category. The slip cast technique was another technology. And just go back to the strength, you see that the strength range for the heat press, it varies from 140 to 450. So it's much better than sintered one, and in terms of strength. The slip cast technique, on the other hand, was a different technology. They had a special die that they laid down the ceramic, a core ceramic on top of it as a core. And these particles of the ceramic were coated with the wax, and when they burned it out, or they heated up, the wax had burned out, and also the core, not the core, sorry, the die shrunk and dropped. That's why it is called the slip cast, which it slips down, and then you get like a kind of core with a porous structure. Then you put any type of glass on top of it, similar compatible one, and heat it again. Due to the sintering and also melting the glass, it infiltrates to those porosity. That's a basic form of explanation. It's more than that, but just I want to make it simple. And you get a kind of a double layered crown restoration. In this category, you have alumina-based, spinel, which is magnesium oxide base, and zirconia. And not that zirconia that we're going to discuss that these days are available. This was the initial form, which has the zirconia as a main composition in the structure. And now we have more sophisticated equipments, machinable ceramics developed, and the machines are developed based on the CAD/CAM system, which drills out the restoration out of blocks, and the blocks are highly sophisticated, they well processed, and then the restoration is drilled out of those blocks. In terms of CAD/CAM system, we have two technologies: subtractive, which is the milling, as we said, that's you mill out the restoration out of blocks. Another technique is the additive, which is 3D printing. It is developing now. It's coming up. It's almost there. Because of expensive equipment and the lasering and all those things, technology is still not popular, but it's developing quickly. And I won't be surprised if within a year or two we'll be in the market for making the ceramic restorations. But what we have now is the milling system available, and it's been available for a while. Initially, it's invented by Dr. Doret in 1971. Because of the expensive equipment and probably the technology was very expensive those times, it didn't gain popularity. Later on, it picked up by Dr. Martin in 1972, 1978. And first they drilled out inlays, ceramic inlays, chairside, which was exciting. Sirona got the patent and they got the contract and they started working on it. And they later developed further by joining to Dentsply. And now jointly they're working on these technology and developing all types of the crowns and things. Lab milling systems are there. You take either digital scanning, scanned impression, or you take an analog impression, send it to the lab, and they will scan it for you, and they make the restoration and send it back. There are also industrial scale milling systems, which are just a few sites or centers in the world globally. It's amazing. You either again scan or take an impression, send to them if it's close enough, and they prepare the restoration, send it back to you. Cemented in
Hi,
place.
Dr. Tauraj.
Yes. Hi.
Yes, sorry for the interruption. That we have got 10 minutes left for the presentation.
Okay. In terms of clinical evidence, evidence shows that there is no difference between these two types of materials in the clinical performance. They do well as long as you do and use it correctly. Feldspathic ceramics are disadvantaged in terms of the strength of it, said that we don't recommend in the posterior teeth, probably on the anterior teeth as a crown, and on the low stress bearing areas. Other than that, other restorations are fine and they do well. In terms of aesthetic, we said that the feldspathic ceramics are much better, and the zirconia is the worst one. The lithium disilicate or the Emax, in other word, is in between. And in terms of tooth conservation, bonded type of restorations are better. This is a new novel CAD/CAM made hybrid materials to overcome the brittleness of the ceramics. All the ceramics are brittle, and in order to overcome that problem, also the wear effect on the opposing tooth, two different materials they develop, which is somewhere between the composites and the ceramics. One material is the polymer reinforced with the ceramic particles, basically is a composite with the higher filler particles in it. Example of is Lava Ultimate. You can mill it and indirectly bond to the tooth structure. And the type is a ceramic infiltrated with the polymer, also known as hybrid ceramics. Vita Enamic is this one. So the main structure is ceramic infiltrated with the resin. In terms of elastic modulus, it's very similar to the enamel, and also wear effect on the opposing teeth. So the patients with the bruxing habit, probably this opens a new window, a new era for the restorations. Long-term results are not available as a crown, but the onlays are doing as good as the other materials, although the strength is slightly less than even Emax. It's around 200 megapascal, but because they are bonded, they are doing really well. And in terms of the preparation, I just, Dr. Kiran, how much time do we have? Or we run out of time? Okay, I'll just finish a couple of slides. In terms of tooth preparation, the crown or onlay, you acid etch and bond it and cure it, and then glycerin on top of it to eliminate the oxygen inhibition layer, and cure it again. And only at the end, one key point, you don't need to leave, and you shouldn't leave the bonding agent on the enamel, and you need to remove that. Just by, if you don't have any other equipments, just find diamond bed, just go gently and refresh the enamel. You don't need to cut the enamel, just to refresh the enamel, or you can use ultrasonic devices to remove that bonding agent from the dentine, so from the enamel, or polishing the stone. All work better. And when you get the, you did the immediate sealing and the dentine sealing, take an impression, send it to the lab, and temporize the tooth. When you get the ceramic back, onlay or crown, you need to prepare the tooth surface, which you do for the bonding system as you do for any bonding system that you're using, doesn't matter. I use 4th generation, and I use adhesive resin cement, which doesn't bond itself, but it needs a bonding agent to bond to the tooth structure. And if you use self-adhesive resin cement, you don't need to prepare the tooth. It says, the company says that you can use directly without preparation, but I have a bad experience with them, so I don't use them self-adhesive. On the ceramic, after trying the ceramic in the patient mouth, the tooth has to be isolated from the saliva. You take it out, you wash the inside, sandblast it, and etch it with the hydrofluoric acid, and then wash it and apply silent coupling agent, keep it for 1 minute to dry, and then use the resin, and you inject the resin on the restoration and place it on the tooth and cure it all around and clean it. Just very briefly, I would say. Zirconias, we said that is, although there is technology developed, this chemical technology, which they sandblast the surface of this fitting surface of the zirconia with the special type of particles, which is silica coated, and they claim that this provides the base for silent coupling agent to work and bond. Laboratory results are good, but the clinical evidence is still not there. So until that clinical evidence is available, we don't consider that as a bonded restoration. And I don't bond you can use bonding system. There is no problem of using, but don't rely on that. Your preparation should be retentive enough, means that you need to have a parallel walls like PFM to provide the retention. Don't rely on the bonding. That's my message. There are products developed to clean the ceramics after trying in the patient mouth, because they believe that the saliva contaminates the surface. Sometimes even when washing, even you apply the phosphoric acid, it's not going to go away. So it's better to use some kind of a solvent to remove that. So they developed like an IvoClean, from Ivocolor, is a kind of a paste made of zirconium oxide particles in an alkaline suspension, suspended in an alkaline solution. You apply to the surface and wash it. This neutralizes and washes away all the remnants of the saliva and ensures the surface is ready for bonding. And studies, I mentioned this before, studies shows that performance of all the ceramics are good except the feldspathic ceramics as a crown. And you need to be careful when you're using that. It's better to use for anterior crowns where you don't have too much of stress on the teeth. And apart from that, other ceramics do well if you use it properly. This is a kind of a brief on what we said so far in terms of the glass-based ceramics, hybrid ceramics, we mentioned that, and polycrystalline ceramics. So in the glass-based ceramics, you have feldspathic ceramics, you have lucite-based ceramics, lithium disilicate. These are the three main that we discussed. There are other types, but these are the main branch of the, let's say, ceramics, and the other ceramics are actually derivative of these ceramics. So the feldspathic ceramics can be monolithic or can be used as a layer on top of other ceramics. They have better aesthetic, that's why. They can be manufactured through the sintering, they're old-fashioned, or can be milled out of block. They are etchable, bondable, yes, mostly used as a veneer. And as I said, if it's a low stress-bearing area, you can use an anterior crowns, but be careful with that. Make sure that is not under too much stress. Lucite-based ceramics, almost similar to that in terms of the use, but they are strong enough to be used as a full crown rather than veneer, and also partial crown. They are pressed and milled, they are not sintered. Lithium disilicate is strongest ceramic in this category. Glass-based ceramics we mentioned can be pressed and milled. It can be used as a core, it can be used on the monolithic, or even layer on top of other ceramics, because aesthetic is still acceptable. They are etchable, bondable, like other glass-based ceramics. They are used for all type of veneers, crowns, partial and full coverage crowns. Hybrid ceramics is almost the same as lithium disilicate. We said that evidence behind the long-term durability of full crowns are limited. So, and they are milled. They are not processed in otherwise. They come as a block, and there's only CAD/CAM system that can mill that out. It opens a new era for restoration of the teeth, especially in the patients which has a bruxing habit, and they don't like metal in their mouth. Otherwise, I would go for gold. Polycrystalline ceramics, alumina is out of market, so there's no point of discussing that. Stabilized zirconia, we said that we have 3 types now available, and also combination of those. So it can be used as a coping, so you can layer it with other type of ceramics. You can use as a monolithic, which mostly we do with the yttrium 3, and the core also yttrium 3 or 3 yttrium. And layered, layer means here is the 4 yttrium or 5 yttrium, and mostly 5 yttrium, just use on the 3 yttrium as a layer. Only milled, and because they are milled, there is no other way of manufacturing, and they come in the form of green form, what we call it, immature form, millable, because if it is completely processed, it's difficult to mill. So they come in the form of immature synthesized or sintered, and you mill it, they mill it and they form it, and they mill it 20% bigger, because during the second stage of heating or reheating, which is the final maturation, it's going to shrink, and that will shrink like 20%. So they kind of compensate at that. That brings a problem of inaccuracy. We said that if you look at my slides, I just jumped at that stage. The problem with the zirconia crowns is, one problem is the opacity, another problem inaccuracy in the margins. And because the second stage of synthesizing or reheating will shrink the crown, but because it's so complex, that the tooth structure is so complex in terms of the shape, the amount of shrinkage in all dimensions is not the same. So we end up with some inaccuracy on the fitting surface and the margins, and the study shows that the average gap is between 100 to 150 micron on the margins, whereas in PFM, ideal situation is 20 to 40 micron. So that big gap is a concern. But the point is, the clinical evidence luckily shows that there is no significant clinical effect. So that's good with that aspect. We are fine with that. The only problem is going to be aesthetic. And on the anterior area, that's why we recommend putting the finish line 0.5 millimeter subgingival to hide that gap. The advantage of zirconia, because of the strength, can be used on top of the other implications or applications, is to make bridge out of it. And some manufacturers even recommend lithium disilicate for making bridge, for ceramic bridge. I'm not convinced with that, because lithium disilicate is a bit weak for that, but the zirconia is fine for even 4-unit bridges according to the company, and I've used it for 3-unit bridges, and it does well. So that is the kind of indication and contraindication. We mentioned this point that we don't count zirconia as bonded restoration. We count as a cemented restoration, and unless there's enough clinical evidence. Probably if you see me next year, my opinion has changed. Depends on the evidence available, but as we stand in now, we don't rely on the bondability of zirconia. Thank you very much for your attention. These are my email address. If you have any questions, apparently here I'm present as long as I can. I am allowed. And thank you for your attention for the whole lecture. If you have any questions now, if you have time, I'll answer. If not, you just send me an email. I'll get back to you as soon as I can.
Something happened. We lost the speaker. Thank you so much. It was a beautiful very, very beautiful presentation. And I have been working with Kiran. He invited me to many of his beautiful meetings, so I'm very grateful. I'm going to share my screen now. I hope everything is in place and working fine. Please verify with me if you can see my if you can see the screen. Last year we organized a presentation in New York.
No, Dr. Dana, sorry. We can't see your screen. I think the file has been corrupted.
Can you see my screen now?
Yes, Dr. Dana, now it's visible.
Yay! So I want to.
Dr. Dana, no sound, I think.
Can you hear me?
Hello?
Can you hear me now?
Yes, Dr. Dana, we can't get
You
your
can.
sound.
1 second.
While sharing the screen in the Zoom, they will show share sound option. Click on that.
I'm terribly sorry. You cannot hear me at all?
Yeah, I can hear you, but PPT sound. I'm saying.
Okay, can you see the presentation?
Yeah, I can see the presentation.
Wonderful. So I'm gonna show you now.
Okay.
This is the group of wonderful researchers. This is in 2005 in Tokyo. Everybody is with specialists, doctors with laser in medicine and dentistry. And this is skinny me here. Now, ever since we try to do as much as possible into the work with laser in dentistry. So you saw the video, you saw this light that heals. This is not for the future, for science fiction. This is a tool that I used for 35 years in my dental practice. Let me ask you if you know what is the definition of laser therapy. There is a laser light, is a cold, invisible light that regenerates. And this miracle of light acts on the ATP of the cells, causing transport of energy and transmitting signal through the cell, in effect immediate anti-inflammatory and in long-term regeneration of tissue, brain, bone, spinal cords, and gum. How did we get to this? First was Einstein. What did he do? He took the laser, how? One electron goes that way, one electron this way, and from the sparkle of light that comes in between them, it causes this stimulation emission of irradiation. So from that we have this light amplification, stimulation emission of irradiation, LASER, laser. And he did that, just the theory, and it took long time, almost 50 years until Theodor Maiman put together the first working laser. Then, 2 years later, Isaac Kaplan in South Africa put the laser in medicine. From that, we got modern medicine. Isaac Kaplan then moved to Israel, and they named the university after him in Tel Aviv. And he was very brave and immediately started to do this oral surgery. And then from that, we have laser surgery and the modern dentistry. Only 5 years later, Professor Menster in Budapest wanted to prove that the laser is bad, and he irradiated, made a clinical double-blind study, and he found in the benefit of using laser therapy. And he was very surprised to see that the laser did not cause cancer, and plus of that, the mice irradiated got better biological constants, their blood tests results are better, and he still could not prove until Tinakaru in the 80s. So is that laser bad? No. Laser is wonderful. Just need to use protective goggles. So this laser therapy depends where in the world was used, different names, but all is actually the same thing. Different laser devices, from which what we use in periodontology is this single beam. And then, is that dangerous? No. Should we put that away? Is that something that can cause harm? No. The sun have the same power of laser therapy, and also you hear about this LED. So ordinary white light comes from the sun together with all the other spectrum of light. What is the laser light? Is monochromatic and is coherent. We can control it, is straight. LED is disorganized, also monochromatic light, but non-coherent. So for our practice, using light to treat gums, to treat the patient, to treat the periodontal patient, we have anti-inflammatory benefits, tissue repair, and then we have analgesia. And to treat periodontium, the bone around the tooth, with the laser therapy, we do bone recovery. You want to hear what are the mechanisms? Let me tell you more about the physics of it. In the spectrum of light, we have heat all the way to X-ray and cell damage. And we have the microwave, we have the infrared, and we have the visible light, ultraviolets, all the way to X-rays. But there is a place where is the near infrared light. This near infrared light have healing powers, and it is the future of medicine. So how can I prove? You see, by the sea, and I am by the sea now. Here I'm at the beach. If you notice, when we have a little money, when we have a little time, we say, let me go to the seaside. I want to go to the ocean. Give me the ocean. And why? Because sitting in the sun is regenerative, the oxygen, and with the sun, and it's good for us. So we concentrated this benefic light of the sun into this laser therapy device. Now we have several types of laser therapy. We have erbium YAG, CO2, photodynamic ruby, alexandrite, diode laser. Why diode is good? Helium neon laser is very important. And neodymium YAG. Now, all of them, they do have this laser therapy action, but for me, the diode that is the cheapest and is the most versatile, very easy to use, is the most important. 630 nanometer, 830 is the wavelengths I've been using all my life in 36 years. 36 years of using laser myself and treating and touching patient. But then I discovered that maybe at 910 we can get even better anti-inflammatory effect. How does it work? Primary, cytochrome oxidase, then signal, right? You put the light on the skin, and then you have this signal, and then you have oxygen that goes and in the nucleus and cause this anti-inflammatory immediate effect. And you have calcium into membrane and 3 types, natrium, potassium channel from the cell, calcium channel, and then you have these nerve conduction, serotonin, mast cell, the soldiers of the body, interleukin, tumors, necrosis factors to fight, and protein C reactive, resolve pain, resolve inflammation, gets to tissue repair, and then to nerve regeneration. So the mechanisms are leading to anti-inflammatory effect, pain relief, edema, enzymatic activity, protein synthesis, cellular growth, all that we want in dentistry, all that we want after an extraction of a tooth. When we have the plug, we put the laser on and we see immediate blood clot. We see immediate anti-inflammatory effect and regeneration and immediate bone regeneration. So we did a study between the two. On one side, we did an extraction without laser, and the other side, we did an extraction with a laser. And we notice the discomfort of the patient is 0. The formation of the clot is immediate. So what happened? One extraction was made in another practice by a journalist. So this journalist then came by a friend of mine, came to my practice. I did the extraction, I did the laser. He put the best giant one-page article in his paper. Big paper. He sent the journalist from his journal, and he took. When you talk with a journalist, you have to show respect. You have to be prepared. You have to make a protocol visit. Respect the journalist that might come to your practice, because that might change your life. Why do I know? Because that happened to me. many times, over and over. Journalist or a patient that is solaire, a patient that talks. I bless the memory of my patient Michaela, who I'm sharing an anecdote now, sorry about that. Michaela, who had one crown on a wisdom tooth, gold. She talked about it and she brought her husband that was very, very, very scared of dentistry, very scared. And the first thing the husband did, he looked at me and he threatened me. He said, if you hurt me, I'm gonna be bad to you. And I said, okay, sit down. I was going actually on a holiday, but I knew he's afraid. He came with a fistful of money. That's a long time ago. I can't believe the time passed so fast. He said, I'm paying you now. Okay. And I'm ready. Okay. She held his hand during 9 root canals, 9 crown prep, impression, and temporary crowns made of composite and curing light there in the site. Next day, the lab made a full, beautiful temporary that we put on. But already with the composites I made just there and there, he already had a smile after years of neglect. That what happened with this young man, 30 something, not very attractive, but very successful director of a chain of gas stations. He was going to inspect the gas stations. And as he did, he showed his new smile. And they got me 105 full mouth reconstructions to do immediately after. It was magic. This very brave woman died of cancer, and the couple separated after because he cheated on her with a lady who was working at one of those gas stations. But when they had a wedding, he invited me and he congratulated me he sang to me at his wedding because I put his smile on his face. And if I wouldn't have had the laser to cause him no pain and no post-surgery complications, I would have this success. Now, Tina Carew, she is the one that gave validity and gave proof to laser therapy in the 80s because she proved the cell activation, cell retardation. Now, if you know, I'm talking very much like a physicist because I am one. I went to master in biophysics and cellular technology. And then to put together my dentistry work and my laser, and to prove that laser therapy is good. And I did prove in so much work of 30 years of speaking in 53 countries, to smaller groups, to larger groups. So to prove, she did all this work. And for me to prove, I went to go to a biophysics work and do clinical studies as much as I could. So then we've been using artificial intelligence in this machine that does laser therapy since 36 years ago. And how? What does that mean? You add in a box, a lot of information, and there it is, and then you give it a signal and the box gives you the information. That is artificial intelligence. And then we use it with all this technology that we have in our practices. To the right side of the screen, you see a painting of mine that I'm doing as a hobby when I want to. Now, Laser in Medicine and Dentistry, this is a book I wrote together with all these lovely scientists, from which many of them, they already died. And we present it at Laser Florence. To the right, you see the view from the balcony of the beautiful Florence. In 2027, we'll have a meeting where, first time in my life, young researcher, I go and I meet first time people that know about laser therapy. Now, my teacher, Agafița Lefter, who put laser in my hand in 1991, 1992, when I first met her, she sent me here with our research. What did we do? And where were we? We were at the periodontology center, depending on St. John's Hospital in Bucharest, in Romania. And she got this machine that costed an arm and a leg. And we started to do laser therapy on the gums of patients. And then we were using it after each surgery. And we were using it also as a treatment in 3 weeks, 3 times a week, to cause this anti-inflammatory, together with chlorhexidine, propolis, irrigations. And of course, before that, we had to do state-of-the-art of scaling, planning, cleaning, curettage, and give regeneration supplements to the patient. So, as we had that ready, then we did laser therapy, and with a successful result. In addition of the medical benefits of the laser light, also is a wonderful psychological benefit of using a non-invasive method instead of surgical with downtown and bedtime and hospitalization. Now, in 1998, NASA conducted the first laser therapy on wound healing for the space, and now it is used for space. In 1999, US military did nerve regeneration, and in 2003, Professor Glenn Calderhart sent the most beautiful message that FDA approved laser therapy. Now, if I ask how many of you know about laser therapy, I tell you it's 0. You know about laser therapy, LLLT used for skin, and it's my fault that not you don't know, but now we change. Now you know. Then so many clinical trials, 500 million, 1,000 million laboratory studies. Another book that we wrote, a trilogy update, because at this time, that's it, 3 books and a 4th book, like this big, amazing. And I spread around the world many of them. And if you notice, this book was published by the European Medical Laser Association. Guess who's the president? Me. Guess who's vice president? Kiran. And Zlatko Simonovic and Leonardo Longo, they founded in 1983. God bless Zlatko Simonovic's memory. He was a difficult man. Now, Professor Leonardo Longo and Patricia Longo, I consider her one of my mothers of lasers in medicine and one of my mothers of professional developing of Dana, me. And Leonardo Longo and Zlatko Simonovic, both amazing doctors, they had a fight because Zlatko Simonovic had a horrible character. God bless his memory. So they had a fight. And then Professor Longo, he created Academy of Laser Dentistry in Florence, and the most beautiful, with the Lions Club, the most beautiful conference that gave me scholarship as I was a child just coming to the conference presenting, and I was very, very young and very skinny. I'm getting skinny again. So at that time, Professor Longo put together laser therapy and brought so many dentists, periodontal surgeon like myself, and the other fields. And I learned from dermatology, from gynecology, from immunity, from neurosurgeon that use laser therapy to put it after in my practice. And let me tell you more. I want you to learn about laser. So let me tell you. So we have class 1 lasers, very low power. Class 2 lasers, low power using pointer. Class 3 laser using printers. And class 3B is the laser that I use, laser therapy. Class 4 lasers are used in surgery, are used in industry, are used for cutting diamonds, which I started to do. So we have the wavelength. What is the wavelength? Is the full cycle between two peaks. So we have one side of electrons and we have another side of electrons. They fight with each other. They go one jet of electrons stream is going one way, one the other way, and the speed on which they go is wavelength and is measured in nanometers. Electromagnetic spectrum, we see depending on the wavelength how much nanometers they are. Like when you see somebody and they tell you they have a laser, you ask, what wavelength? Repeat after me. What wavelength? Because the wave is how is the jet of electrons that cause the sparkle, which is the photon, which is the particle of light, which is the reason laser happened. So then they say, my laser is 488 nanometers. Then you know it's blue. It's argon. And then they say, my laser is 530. And you know it's green. And you know it's a diode. And then is 600. Then you know it's from yellow to red. And then it's 755. And when it goes to 760, that's it. No more. You cannot see the color. So when you use the hose to water the garden, you see the rainbow after the rain. And you can count all those colors in the spectrum of light. And you know what wavelength are each color in the rainbow. And then between you and me now, we have this light. This is transparent light. This is infrared light. But the magic of medicine, instead of using a knife, we can use this light to heal. How about that? Huh. So, how we calculate this light? We calculate milliwatts. What is the power on centimeter square? And you have the beam area. And on the beam area, you see, so we have the way where this laser light goes through. It's active, and you have the power. How much power? But you're gonna laugh about it. That you don't need much power. You need very little, just light, tick, and the light, it goes into the oxygen and gives signal, and the cell open. Now, am I the living proof of the benefit? Because I used it all my life. And I see girls 56 years old as me that look much, much older. I see 40 years old girls that look much older. And it is the power of light. Now, how can we use this light? We can use to regenerate, to stimulate, or we can use to inhibit. At my first presentation, Professor Glenn Calverhart, who after invited me to Tokyo, I was a skinny young researcher from Romania. And he loved my presentation and he invited me to Tokyo. But before that, he asked me one question to see if I was lying, bullshitting, or if I was saying the truth. What did he ask? He asked, what did you use? Pulse or continue? Now, if you use pulse, then you cause regeneration. If you use continue, you cause inhibition. And this is related to this bell curve that was proved to show how using the light in pulse causes the stimulation, which we want when we want to regenerate bone, regenerate gun. And we want to inhibit, cause bleeding stop, hemostasis, cause pain relief, in immediate effect, cause anti-inflammatory immediate effect. We want inhibition and we use continue. So we use light in two ways, and we have the power, we have the wavelength, and then we have the frequency, which is the pulse frequency. Again, you can hear all kinds of names. Photobiomodulation is the last one. Laser therapy, cold light, LLT. When I started, I knew I'm using low level. Why low level? Because it's cold, doesn't give heat. So it's low power. Laser is used in all the fields of medicine to heal. Veterinary, geriatric, diabetes, nose and throat, Alzheimer, neurology. But in my case, maxillofacial surgery, periodontal surgery, oncology, and neurology. And gynecology, we did with EMLA, we did create a laser and we presented that for our friends. In oral mucositis, we found in the benefit of lasers, incident of ulcerative oral mucositis in patients was treated with LED with great success. We see the benefit of using laser therapy. Also for the tendinitis and for maxillar articulation, for the neck pain. Also, laser therapy is used to replace NSAIDs, Tylenol, ibuprofen, and with lower cost, more effective, no side effects. We all know that NSAIDs inhibit tendon to bone healing. We also know that intra-articular steroids and pain relief is better to use laser therapy than to use NSAIDs. So if you have steroids and if you have laser therapy, use the laser therapy to begin with. We know that ibuprofen, if it's used more than 3 months, makes 70% damage of the immunitary system. We know risk of heart failure. We know that NSAIDs is the 15th biggest cause of death in United States and raised risk of erectile dysfunction. So if the patient have pain because of the tooth, instead of giving a ton of ibuprofen and Tylenol or whatnot, painkiller, ask them to buy an infrared laser light to put it on the area, and you will see the benefits of that. And that once the patient have that machine, then it's free. Collagen synthesis was proved to be benefic in wound healing for anti-inflammatory gum treatment. Also, post-operatory pain is much better with the laser. For the cartilage, after knee surgery is much in the benefit of laser use in any type of chronic pain, in different neurological complications. What is this 830 nanometer? Means is transparent light and penetrates the tissue and have an effect inside, not superficial for the gums and right direct on the alveola or on the tooth or on the root canal. No, inside, through the cheek, penetrating skin, mucosa, bone, ligaments, arriving to the apex of the tooth to treat directly. So the magic of infrared laser therapy, cold light. Overall, the fracture was shown to heal even at horses with use of laser therapy. So we have tissue, cell, mitochondria, electron transport, C oxidase, and SDP that cause this signal from the light to cause regeneration, upregulation, and all the way to nerve regeneration. And then I want to show you here. LLLT has much better healing than steroids. On the spine, as you go and you apply the light, you see how it penetrates the tissue and go all the way, even to 8 centimeters in the body. In our case, to 25 millimeters. For the spine and for us, for the bones of the maxillaries, with benefic effect. This is a slide from the work of Professor Leonardo Longo, who took patients out of wheelchair. So let me show you a clinical study. We enrolled 100 patients. Some of them, they received laser, some of them not, and some they were younger, some more mature. We used several parameters: inflammation, pain relief, recurrence and reduction of antibiotics, and full regeneration. So some of them, then we separate them in 4 subgroups: healthy, toxic, hepatic, and kidney problems, diabetic patient, calcium metabolism problems. And from that, some of them, they were healthy, some of them, they were with iatrogenic problems, some diabetic. So this we diagnosed that everybody had periodontal disease at a level about with a loss of 5 millimeters of bone. And the diagnostic was based on local and general condition. So what we did state-of-the-art prophylaxis, anti-inflammatory, local and general. We did scaling and planning. We make sure that the blood tests were fine, that the patient was stabilized, well nutrition, calcium level okay. If they had kidney problems, well medicated. The immunity system with vitamin C, with changing a diet, with a lot of eat. We ask the patient to eat like a goat to get oxygen from eating lots of greens and juice and all that, and taking everything to increase immunity system. We make sure also that we did full mouth reconstruction to make sure that the forces on each tooth are balanced and not oblique forces. Everything is vertical and safe, and everything is clean, and every inflammation is gone. We give local treatment to use at home. What? Brush after every meal. Then use chlorhexidine gel. Use propolis B liquid on a Q-tip, 2 drops, and then touch interdental space for each gum 3 times a day. Especially at night, brush from red to white to make sure that the gum, it stays on the tooth. And if you brush from right to left, the gum will leave the tooth and it'll cause trauma. And at night, make sure you have propolis on the gum, because the propolis have enzymes and is regenerative. So what did we get out of that? We got this wonderful regeneration already. And only then we start laser therapy. How? The dose of 0.5 joule per centimeter square. Joule is made by watts with the power and the frequency. So what we did, we irradiated each interdental space. Then we scan entire surface on the outside. All together with a fluency of 2 joules, and not to get more than 16 joules that day. We did mostly a protocol of 9 sessions during 3 weeks. And if we did a surgery, we did post-operatory, having the exposed periodontal space, and then having on the outside. In some cases, because of immediate hemostasis, we did not need suture. In cases where suture was needed, we irradiate again after the suture. So first, in the open surgery side on the periodontium, and then after. LLT was applied, anti-inflammatory local treatment continue, and patients are monitored every 3 months, every 6 months. And what did we notice? We noticed bone regeneration. Now, when they tell me that they use this laser therapy that causes heat, That is a lie. They don't do laser therapy and the results are fake. Because laser therapy have to be as cold as me putting this mascara on my hand. Mascara container. This putting this plastic object on my hand. That's how cold it is. Laser therapy does not cause any heat. And the frequency, no GF frequency, 4.89 Hertz and 9.12 Hertz. This is the no GA frequency that we use. And with this frequency of light, pa, 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 and with this dose, with this infrared light, it's the miracle of life. It causes anti-inflammatory effect. This is me. This is an image from 36 years ago. You see here the ants. You see the machine. That's the old machine with artificial intelligence in it. Immediate anti-inflammatory effect. Irradiation was made. So what did we got? We got tightening, we got pain relief, anti-inflammatory effect. Use of treatments was less, use of medication, complete healing, and no recurrency. So those are our parameters we studied. We have the results in the control group and laser therapy group. We found all in the benefit of laser therapy group for all the type of patients, either if they have hepatic problems, if it was an osteopathic disease patient, or like that. And then no medication was used except one was absolutely necessary, only laser. And for pain relief also, we found in the benefit of the laser on all the control groups and all type of patients. And rapid anesthetic scar was found, healing of soft tissue, restoring of function, and local elasticity maintain healthy aspect. For the diabetic patient, laser therapy is very efficient and treatment was used with light, faster healing and more secure. In both groups, we found in a benefit of laser. No recurrency was found except in the control group where laser was not used, and no medication use. So, in conclusion, the results of the work is that the benefits of using laser therapy in all your practice would be making life easier and the shorter pain recovery time, reduce post-surgery complications and edema, infection, faster natural maintaining of the function, masticatory function and aesthetic function. Biostimulation is promoted, regeneration of tissue and recovery. In conclusion, use laser and there were no abstract adverse effects. I was very happy to find that laser therapy is used for Alzheimer. It is used for post infarctus, myocardial infarction with great, beautiful regenerative effect of the muscle. And let there be light. Please come to the next conferences of Kiran. Kiran, thank you for having me, and let there be light. These are, I have another, just few slices. These are the COVID victims at the choral, at the Purim festivities, a holiday in Cannes. Purim is a holiday of women. At my synagogue in Cannes, and all of them, they died because of COVID. Why? Not because they got this so-called COVID, which is glorified rubella, measles, mumps vaccine is treating it, just because they got iatrogen bed treatment. They exploded the lungs at the hospital. So this is in 2019, a picture taken in China in 2019 that showed they already knew about this spread of man-made virus and man-spread virus that, if you notice, killed elderly people. Why? Because they did not get vaccinated against measles, mumps, rubella as they should have had. So the life turned. People got isolated, and they blamed this. Actually, you know what happened? This horrible man Fauci sent in Wuhan this biological weapon called COVID to make this virus, which is from a man-made. You can buy for laboratories. You can buy this virus to make research. And they make it, and they took it back, and they caused this fake pandemic that killed so many people, including my dad. Shame on Fauci, shame on the killers of a massive part of population. And then for commercial reasons, they created more vaccines, and then we have this triple milliard of dollars industry of vaccines. Shame. Then 2020, Clorox became the perfume of the year. Now, I told you, I did dental school, good for me. Then I did the periodontology, and then I entered to the master in biophysics and cellular technology. And I studied because I was an A+ student. I still am. So, what did I study? I studied that in a pandemic. It's a bell. Yes, pandemic go up in a heap and then go down. Doesn't exist this curve that you see here, going in many peaks, doesn't exist. That means it's man-made and man-spread. Coronavirus, so-called pandemic. And then the symptoms of coronavirus, they look so much like measles, mumps, rubella. And then we look at the pandemic for age. So no children. Why? Because they got vaccinated immediately. You know the 12 mandatory vaccines. MMR vaccine is one of them. And then also very elderly as well, they get vaccine at 70. You have to vaccinate yourself again. So then we have the population of more mature adults that got hit by this so-called COVID. You see the mandatory vaccines, we don't know, we forgot, we are dentists, what do we know? And so it's one of them: diphtheria, tetanus, capeluche, hemophilia influenzae, hepatitis B, pneumococcus, meningococcus, MMR. This is COVID. This is anti-COVID vaccine, and papillovirus. Those are the mandatory vaccines. And this one at birth, then 2 months, 4 months, 11 months, 12 months, 14 months, 6 years, 13 years, 25. But at 43, nobody goes to vaccine. At 25, nobody goes to vaccine. And then after 65, that's why, because they got vaccinated by this MMR, those group of population did not make COVID, because COVID and measles, mumps, rubella, rougeole, aureole, rubeole is the same thing. Who said that? Me? No. We know they are both, all of them coronaviruses, And this COVID is made in the lab, fuck them. Sorry, pardon my French. And then Professor Adams in Cambridge studied the DNA of this COVID and found that it's the same of measles. The same. It's the same RNA. And then they proved in April 2020, they proved that it's the same. So that was not nice. Shame on Fauci that caused that to spread all around the world. So at the beginning of COVID, I published this article that was very well received when I showed that the MMR vaccine is effective against COVID. And we did in all the region of Côte d'Azur of French Riviera. I ordered from India lots of vaccines, and I vaccinated as much as possible in generosity of European Medical Laser Association, a large population of my people there, but not my dad, because was not in the country and my dad died. This is a light as a potential treatment of pandemic coronavirus infection by Chukuka and Wemeka, my wonderful colleague and friend, Dean of New York Institute of Technology. What he did, he put the laser on the bronchi and lungs and proved that laser light killed bacteria, killed viruses. Now, at that time, President Trump he said light therapy, use light therapy against COVID. They laughed at him. I wish I had more courage to talk. I wish I did. Why? How he knew? Because he was exposed to luxury medicine, to luxury therapy. Because for now, laser therapy was supposed to be in the pockets of each person on the world, replacing an aspirin, replacing an anti-inflammatory paracetamol, ibuprofen. He knew, and he said it, and nobody supported him. And we were all too afraid to talk. I'm taking you to another subject, very dear to me, post-traumatic stress. If you have a patient with that, and we all have patients, you take them to remove the victim from the focus of violence. If you have a patient with a abusive husband, you tell her to go away so she's not hit again. Make sure her belongings are safe, because the reason a lot of people they end up on the street, or they stay even if they get beaten, because they have nowhere to go and they don't have a means, or their belongings they get robbed. Be aware of theft or crooks that will take advantage of victims of violence. Relocate the victim either in another city or another country or another continent. Happy boost of moments of intense joy. Dance, music, good surprises, light. Last night I went to a global care foundation, and it was a very successful event, and it was a DJ, and immediately I went and danced, and it was wonderful. And because of that, I made lots of friends. The victim have to surround with people that are trustworthy and they truly have best interest of the victim. And that victim have to do something that is so interesting, they will forget what happened to them. Those are the 5 steps of healing for post-traumatic stress. No medication. Medication will not help. This victim is not a mental illness. is just somebody that went through an extreme traumatic event. These are the steps, and they are published. So no medication is needed, and recovery can be made with restitutio ad integrum. This is the very first AI machine 100 years ago. How did they do? They put the logic and the tape was recording stuff, and Turing did the first artificial intelligence test. Alan Turing. He put the machine and the human, of course, the machine won. Then over the years, artificial intelligence was very successful. Then they lose interest for it, and it caused machine learning, deep learning. It's just us and with the plug. And if we pull the plug, it's no artificial intelligence. So let's see, what is that all about? We are human. We have memory, perception, anticipation, problem solving, decision, and the machines, they have language, they have vision, dialogue, domain, machine learning. Now, if we put several scenarios in the machine, and then if we put several results, and if we put more options, we give inside the machine a logarithm that makes it look like thinking, that makes it look like artificial thinking. So imagine how smart is this ChatGPT, who is actually at the base of all artificial intelligence. How smart it is, because it got all the wisdom of the world, mine, yours, entire planet's wisdom is inside. And then if you create a project and you put everything about you inside, and then you ask a question, when you ask the ChatGPT, you ask all the wisdom in the world, and you are more powerful because you have that. So I'm using, and when I'm using it, it feels like I have 30, 50, 100 people helping me. Please use ChatGPT, create yourself a project, create yourself several projects in little boxes so that ChatGPT know how disciplined you are. Don't put too much. Put everything about you inside. Put everything about the project. Try to put it in Word, not in PDF. Try to give image, and you'll get the best result. Use it is important. The benefits for cybersecurity are massive. In diagnostic is, of course, in medicine so much used, and for robotic surgery, which is controversial because you are in one country and you want to use surgery in this country, so you have two teams, and you are based on the team in Bangladesh and you are in Berlin, like Professor Michael Stark, and then things can happen wonderfully or things can be bad. Imagine how a nurse can carry a body of a handicapped patient. Impossible. For that, we got this robot to be used. Now, if I am not good, I hope never, if I am on a bad side, I hope to have all the artificial intelligence machine around me to help for measuring diabetes, for the heart, for everything, for assistance. Yeah. So legal and ethical consideration. Now the robots have rights. And that's funny, and the accountability is important. Artificial intelligence in healthcare became very, very, very much used. A friend from Boston just announced me that she doesn't want anymore to have a nurse and reception and employee And she is not proud of it, but she works less now. She have less overhead. She have 3 less salaries to pay, and everything for her is done by artificial intelligence. Appointment taking, reception. It's crazy, but it's true. I heard the other day that only the ones that they will use artificial intelligence, they will keep their jobs. And the ones that they don't use artificial intelligence, they won't keep their jobs. So if you start to learn, it's a little learning curve. It's not that bad. You will keep your job, and you will manage to give jobs to another people. Make your own business. Don't get a job. Make your own business. So as you see, now let's see a nurse. AI is made for Naomi because she's a victim of violence survivor, just like me. And she is a handicapped girl in an orphanage in Tanzania. Now, if this orphanage will have an AI nurse and they will have an AI pharmacy dispenser with dosage medicine, 1 dose at a time, those children, they will be healthier because there is no nurse, there is no doctor. And a child in Tanzania, if they go to doctor, they have to pay. And how these children, they have money to pay? They suffer of malnutrition, they've been abused, and they are now rescued in this orphanage. And this orphanage, oh my God, they're heroes. So artificial intelligence is made for them. Be aware of deep fake. Deep fake is very bad. They used to cause fake stories in the news. It's so bad. That's disadvantages of artificial intelligence. Make your own decision and don't learn from the detail man. Who's the detail man? Is a person that comes and tell you, just study. Mercury is very toxic, and that was used in medicine. This is the 4th topic I want to talk about today. And mercury caused this terrible poisoning, Minamata disaster. Now, as dentist, if you have 3 of those systems, then you are a victim of mercury poisoning, and that cause autism, infantile acrohilia, infantile acrodynia, can go right into the lungs and into the bones, must be removed. A detox must be done. This is mercury germ analyzer all the way to 0. And let's hope we'll have this beautiful hat and not the Mad Hatter disease, which is the mercury disease that was the disease of people that were polishing with mercury those hats in the last surgery. Another last subject is albinos. Did you know that protein P in lack of protein P at the mother caused the mother to have children with no melanin, and that is the albinos disease only reason? We went with EMLA and we did this, and we made them in the orphanage, we made them bedding, and those are our children in the orphanage. Please stay close to us, to HK and to EMLA and to Kiran's work and to my work. Don't be a stranger, and let there be light. Thank you very much. I finish my presentation now. Any question, anybody? If you don't have any question, I want to tell you how much I appreciate. I want to stay in touch with each one of you, and I want to show you the love for our patients is important. So these are my details. Let me put them on the screen somewhere here. If you want to come to New York, you're more than welcome. And let's there be light and beautiful meetings.
For Bangkok
This
conference also, Dr. Dana.
a Bangkok conference, please come. Now, why we go to Bangkok? Because when I was victim of violence, 2018, I went to Bangkok and I healed over there. How Bangkok is a very giggly place, and one massage is $2.85. So I had 5 massages a day. Kira knows because we did a meeting. We met in Bangkok to prepare. We prepare meeting. We prepare the meeting we had in April and the meeting we have in Bangkok. So if you come to Bangkok, it's very beneficial for your health. It's very cheap to organize a conference, and in Bangkok, many people from all around the world, they came, as we like to welcome our scientists from the Middle East and from Asia, from India, from Taiwan, from China, from Indonesia, from Thailand, and from Europe. So because it's a destination easy to reach and it's such a benefic place, we decided to have a conference in Bangkok. We are very happy to have a very large British delegation, French delegation, Taiwanese delegation, Chinese delegation. So please come, and Australian. It's going to be wonderful. The next meeting we have is with United Nations. We invited all the first ladies, and it's going to be on the 18th of September locally here in New York. We have the room Grace of Borough of Manhattan Community College. And then 22 of November in Bangkok. I have another meeting in Paris for Alzheimer before the Bangkok meeting. And then Dubai in March, either on Zoom and or live. And then also next year, benefit of Borough of Manhattan Community College, EMLA and HK conferences, they will have free venue for the conference, which is very, very good news because for New York standards. And if you want, Kiran,
Dr. Dana.
can I show some of the pictures from the last conference?
Yes, Dr. Dana, you can.
Okay, I just send them to myself. So after 5 years of presenting as a speaker, thank you very much, Kiran. Very generous of you over 5 years in many AI meetings. Where, what did I know? I learned just watching the lectures of our colleagues. So after 5 years, then Kiran asked me if I can do a lecture, a conference live in New York. So after all this year of Zoom and being isolated, we decided to make a first live conference in New York. And it was magic. Unfortunately, Kiran and Kavya, they could not come, but I was there. And I hope you see the screen. Let me show you. This is one of the tables I created myself with the flags as
No,
we
Dr.
celebrate.
Dana, we can see your PPT presentation, not previous conference slides.
Oh, okay. I'm putting it in right away.
Your mobile number, Twitter, LinkedIn, those are the details we are able to see.
Now the presentation is out.
Yes.
Okay, I stop sharing the screen. I reshare the screen. I'm gonna reshare entire screen because I was sharing just the... Now can you see?
Yes, Dr. Dana.
So this is one of the tables. And we prepare for the gala dinner and for the lectures. This is next conference is in Las Vegas. Next conference is in Las Vegas. Okay, next picture.
Dr. Dana, put chargers.
Yes. This is when we give Lion of the Year award. And this is one, because we had opening ceremony and closing ceremony. This is at the closing ceremony. I did not had much time as I ran around all day long, and this is the group of speakers. Beautiful, beautiful crowd, beautiful magic. Everybody said they will come again. Some of the speakers at this moment, they already left. Some of the speakers, they already left. You see Professor Lingam and everybody else. Beautiful, beautiful conference. This is in the first day, and we've been congratulated for having very, very, very good quality scientific content by the amazing level of speakers from many universities and countries, 32 countries. So we are very proud. We worked very, very hard. How many months we work for it, Kiran?
Nearly 9 months, Dr. Dana. 8 to 9 months.
From October. This is the room preparing for the gala dinner. Magic. We behave very well. The Palace Leader Crowns Foundation, they will let us have a meeting later. These are some of the posters. So you see Professor Said from Harvard, Professor Veronique Petit from France. She runs forensic and DNA tests and protective tests for women to see if their drink was contaminated by drugs, or if they were raped, to see if they were drugged right after. DNA tests, amazing work. Professor Dave Cameron from Benedict University, this wonderful young man, Fourier Kari, Professor Patrick, so many beautiful, Marie Petit, AI in Pharmacy, wonderful speakers, wonderful scientific content. Here we have the flyers when we announce the Bangkok conference and picture and everything. And also we had the DJ, we had the Sal Sinatra, and this is the lecture room during the day. So we had this room for lectures. We had a full room with students, faculty. We got very much good feedback out of it. And also we had coffee, cookies in the hallway. The hallway is very good too.
TDMI.
And this is all thanks to Kiran. Everybody that came together, International House of HK. Yeah, we did the badges, we did the bags, we prepared well. We prepared really, really well. Right, Kiran?
Yes, Dr. Dana.
We did so well. Now our work with, I really hope you're gonna come to the meeting in, to the next meeting. This is in Las Vegas. I forgot to tell you, American Laser Dentistry Organization makes this this event. Is gonna be in October, and I'm gonna create EMLA night. I'm gonna create, maybe if I go, I might do it on Zoom. But if I go, I'm gonna create EMLA night. I know those people since 35 years ago, so I should go. I wish doctors get to have the power, but I think less and less doctors have any power, being at slaves of insurance and industry and stuff. That is a shame, but we keep optimistic and we study and we learn every day and we progress. So what can I tell you? Otherwise, thank you very much to all of you, and please keep in touch. Is any other speaker, Kiran?
No, Dr. Dana. We can close the day.
We close the day, and I wish everybody a beautiful, wonderful life.
We'll see you in November conference.
Yes, please come, either online or Zoom. Must come in November. It's going to be beautiful. And we know to create the most beautiful time. And there will be lots of gifts. So come. Lots
Yes.
of love.
Thank you, Dr. Dana.
Thank you. Bye-bye.